Good morning, and I think that we have concluded our testing for this morning. I am Wayne Tuckson. I have the pleasure of being the moderator for our session today. For those of you wondering, this is day 2 of a two-part session. We had the first part last night. Good to see you, Pastor. The first part, again, was yesterday, and the session is on caregivers, conquering cancer, advancing health education and equity, and multiple myeloma. And yes, we can use the word equity in this setting. The program is hosted by Shaw Temple African Methodist Episcopal Zion Church, with the Reverend Eldrin Morrison as the pastor. This is also in partnership with Kite Pharma, a Gilead company, and the HEAL Collaborative. The program, not only are we having it live here, but there's streamed, and it'll be available on the web, and also apparently we're going to have some radio commentary throughout the day. What station is that, by the way? Really Real Radio. Outstanding, outstanding. Before I continue with a rundown of what happened yesterday, I'd like to have first greetings from Pastor Morrison, who will get us started, and then we'll bring up Mr. Stanley Watson to give welcome from HEAL. Pastor. Good seeing you again, sir.
Good morning, everybody. I'm again Pastor Morrison, and happy to welcome you here at Shaw Temple. We are pleased to be able to house this wonderful 2-day event that is sharing so much information and a valued conversation with our community. I just left visiting several members at the hospital and rushed over here. I was asking everybody if they knew Dr. Shepard and everybody else there. But we are really in a good place where faith and medicine and treatments collide or really intersect. And what we're doing in these 2 days is so meaningful for not only our church but for our community. And so I'm excited about the information, the conversation that we'll have even today. So thank you so much for being here. And if you need anything, just let one of our members know. Pray. Let's pray. Our Father and our God, we are grateful for the opportunity to come together again on today. I pray right now, Lord, that you might bless the time that we spend together, that information, yes, is shared, but that inspiration is gained. I pray for caregivers. I pray for those who are receiving care. And I pray, God, that healing will take place in our homes, in our bodies, and in our community. In Jesus' name we pray. Amen.
Thank you, sir. I'd like to bring up Deacon Stan Watson. Stan is a former Georgia State Representative, which means he is long-winded. We'll try to get the hook on him. But he's also the Religious Outreach Coordinator with HEAL.
Thank you so much. I think the pastor did a wonderful job. Will you get a pastor a hand at Shaw Temple? Give everybody a line, give a hand. Thank you so much this morning. We are happy here as an organization to be here with you this morning. On behalf of HEAL Collaborative, our staff, and all the workers that put this together, we thank you for coming out this morning. We hope that you actually will be not just hearers of this word, but as we say in church, be doers of the word. I think the pastor would be the first one to say that a tithing member cannot tithe if that person is sick. So if that person's in the hospital, the offering goes down, and we may lose a member. So we want to make sure that we be proactive in presenting everything we can for you today. So we hope that you take this information not only from the church, but to your community, and make sure that we use it effectively. We have subject matter experts with us today that will provide a great platform of information that you can take home, take to your community, and share with it. We have a great moderator. I don't think I have a problem with it. He's from Kentucky. And he's going to do a good job in sending us through this program to make sure that our platform, our organization, and all the information is done again. So on behalf of HEAL and our board of directors and staff that's present today, we look forward to serving you, and make sure that you take the time to look at those surveys that's on your desk and make sure that we can take care of you in this opportunity to present to you this morning. Thank you so much.
Thank you, Stan. And let me stress again the importance. If you notice in the program, there's a survey, there's a pre, and then there's a post-survey. Please fill that out. Fill out the pre-survey right now, and then at the end of the program, fill out the post, and we'll be happy to pick those up. That helps us know if we're on the right direction as far as how we're getting the program. As I mentioned, that this is done in partnership with Kite Pharma as part of the Gilead Corporation right now. And let's just get a stand-up we good from Leslie, Allie, Kathy, and Rolando. Please stand up. They're from representatives from Kite. And we said it yesterday. Thank you all very much. We said it yesterday. How many of you can name me any pharmaceutical company that you want? Who knows the name of a pharmaceutical company? Throw out a name. Sanofi. You don't count. Name me one. Go ahead, name one. Eli Lilly. How many times have any of you met anybody from those companies? You. I mean, you know them personally? Oh, we got another ringer up here. But, I mean, the point being, it's unusual for a large pharma company to come in to our homes and give us information. So please avail yourselves of the opportunity to talk to the representatives from Kite Pharma. And they are part of, as I said, the Gilead Pharmaceutical Company, but talk to them and ask them, you know, if you have a question about it. Now, today's program is going to be pretty interesting. Because yesterday, we're going to pick up where we left off yesterday. Yesterday, we learned that 1% of the population in the United States develops multiple myeloma. We also realized and learned that African Americans have a higher incidence and mortality rate, as in many things, from multiple myeloma. Even though we only make up 14% of the population, about 20% of the patients with multiple myeloma. Survival rates for multiple myeloma, as we heard yesterday, are improving, and we'll hear more about that. We found out the importance of community support, be it our friends, family, but people outside of us, and the importance of having good groups, support groups. And we heard about some of the support groups that are available for patients with multiple myeloma. Being a boy out of Washington, D.C., which is along the Chesapeake Bay, I heard the use of the term crab. Now, usually we hear crab, we think about Chesapeake Bay blue crab. For those of you not familiar, it's the most finest eating you ever had in your life, especially if you couple it with a beer. Yes, I'm saying a beer here in the church because they go together perfect. Perfect convolution of evolution, the development of a beer and the Chesapeake Bay blue crab. But anyway, what we found out about crab was hypercalcemia, renal disease, anemia, and bone pain. These are some of the things to think about when we talk about melanoma. We heard about that, and we'll hear some more. We're also learning that attitude is very important. If we have symptoms or things, seek out care. Don't sit around and wait and procrastinate like, as we heard yesterday, a lot of folks, particularly African-American men, we like to wait till the last minute to do things. And African-American women, so worried about taking care of everybody else, don't always take care of themselves. Today, though, we're going to hear more about what is CAR T-cell therapy. We're going to hear a lot about that. We're going to find out who gets treatment, when, and how does this treatment work. Talk about the different meds. How were they developed? And what is the process of developing new medication? And what do we need to know about clinical trials? A lot of us hear these terms about clinical trials, and we think some kind of hocus-pocus stuff is going on. But let's break through the myth and misinformation associated with things. Let's find out about what really is going on. We'll hear about the experience of a caregiver as she accompanied her mother through her journey of diagnosis and treatment, particularly with CAR T-cell therapy. Learn how to navigate the system after the diagnosis has been made, and hear about techniques and the need for self-advocacy. These are the things which we're going to accomplish today. And after our speakers have had their chance to speak, we're going to bring them up for a question and answer session where you have a chance to ask questions. So I want you to think as the speakers are up there that, what questions or things you want to know, and you can write them down. We did have some questions from yesterday. We're going to go back and pick some of those up so we can make sure we get the answers. But we also want to hear what you have to ask us today. But to get things started, our first speaker is Dr. Brandon Blue, and he'll be speaking to us about available treatments for multiple myeloma. Dr. Blue is a graduate of Meharry Medical College down in Nashville, Tennessee, a good place unless you go into Howard, but we'll talk about that, Dr. Blue. He did his residency in internal medicine at the Washington University in St. Louis, Missouri. He did a fellowship in hematology oncology at St. Louis University, also in St. Louis, just down the road from Washington U, and a fellowship in blood and marrow transport and cellular immunotherapy at the Moffitt Cancer Center. He's currently in practice with the Moffitt Cancer Center at the Magnolia campus, and he's an assistant member of the Malignant Hematology Department at Moffitt Cancer Center. One thing of interest, though, about Dr. Blue is you can see what he looks like. And he was asked a question about the need for diversity. I don't mean just wearing a bow tie versus wearing a tie. But he was asked about that. And I think when we look at these times of diversity and how that's come under attack, and you can't call it coincidence, it is an attack, an affront to our very being. Dr. Blue responded, since, and I'm going to paraphrase, but since we have patients from all walks of life, having providers from all walks of life can only enhance the experience. And I think Rolando will agree. This goes to the message from Kite Pharma, and this goes to the message of HEAL. There are a lot of us out there, and we have to bring these diverse experiences to play. I give you Dr. Blue.
Thank you, sir. Appreciate it, brother.
Yeah.
All right. Thank you, sir. All right. How's everybody doing? Wonderful, wonderful. God is good, right? Okay. So what I want to talk to you guys today a little bit is about what I do every day. So I am a cancer doctor. I see people with a very specific cancer called multiple myeloma. Now, I see people every day, like meaning that the first person of the day, the last person of the day, typically all have this disorder. So this is something that I do every day. And so they tell me that I'm an expert. I don't know, but it is something that I'm pretty well versed about. So I want to make sure that we leave here kind of understanding, like, what is this cancer? What are some of the treatment? What can we do about it? And just kind of making sure that we can help people, okay? Now, before I do that, I was hoping I could get maybe 3 volunteers. Any 3 people want to come up here for a second? Maybe Pastor want to lead by example and come up here for example. Anybody want to join the pastor and stand next to him? All right, wonderful. Wonderful, wonderful. And then maybe our moderator, if he could come here for a quick second, that would be wonderful. Okay. Oh, we got, well, okay, perfect. Thank you. Wonderful. Okay. So what I just want people to understand is for this disease, what happens is that this is a cancer of the bone marrow, right? So now we in the South, all right? So we know that inside of that bone, right? Come on, talk to me now. We can eat that marrow. That's some good eating. You know what I mean? Some people even make a soup out of it because it's good, okay? So just know that inside of your bones, if somebody was to chop your bone in half, it's not going to be solid bone all the way through. Inside of that bone is the bone marrow. So you say, well, what we got a bone marrow for? What's the reason that we have a bone marrow? Is that it's what makes our new blood. So the same way you get new fingernails, you get new toenails, you get new hair, well, you also get new blood, all right? So the blood that you had when you was 20 is different than when you was 30. It's different than when you were 40, different when you was 50, because inside of that bone marrow, you keep making more and more of those blood cells, okay? Now, the job of the pastor is to make the white blood cells, okay? Now, these white blood cells basically prevents us from getting infections, right? So whenever we have COVID, the flu, pneumonia, pastor's gonna get strong and say, hey, I can take care of that, okay? Now, sister, what's your name?
Lee.
Lee? All right, so Lee's job is to make red blood cells, right? So red blood cells is how we get oxygen. So I want everybody to take a deep breath. You breathe in the oxygen, breathe it out. Now, that oxygen has to go to your brain, your hands, your feet. So what happens is that Lee has to be almost like a bus driver, take that oxygen that you just breathe in and bring it to all the different places that need the oxygen, okay? And then what's your name, sister?
Naomi.
Naomi. So beautiful Naomi here, she's going to be what we call platelets, all right? So platelets are the things that stop you from bleeding. So what happens is that let's just say you get a bloody nose. You pinch your nose and you like, it's magic. I just stopped bleeding. Well, really, it's because Naomi was here doing her job and stopping you from bleeding, okay? And so these 3 things are happening inside of your bone marrow every single day, all right? Now, as they continue to work, what happens is that y'all spread out a little bit. They got plenty of room to do their job. Nobody bothering them. They doing things the way that they supposed to do, all right? The issue that comes in is when, I don't know if anybody here ever had somebody come to their house and just act like they just don't want to leave. You know what I mean? And I'm like, you start to give them hints. You like, all right, y'all, I gotta go wash dishes. I gotta go take a bath. They just not going nowhere. And not only that, they call their friends, and they got more people. And I'm like, why are all these people in my house? Right? And so that's what ends up happening when you get a cancer. So if we think about this room being the bone marrow, again, they spread out, they got plenty of room. Now they got all these uninvited guests in there. They get cancer of the bone marrow. Now y'all squish together for a second. Now, they used to have plenty of room to do their job. So now that this cancer is inside of their bone marrow, what's happening? They squish. And what happened when we squish? They don't want to work. They don't want to do nothing. So what does that mean? The white blood cell, looking at Pastor, we get COVID, we get the flu. Pastor like, I can't work. What you want me to do in here? I got all these people in here, right? So unfortunately, what happens when people get this cancer, what happens? The immune system goes down because the white blood cells can't work like they should. So then we go right here to Lee, and Lee's like, hey, I'm supposed to be working and bring that oxygen. So you breathing, but the breathing and the oxygen not going to where you needed to go. So what happens? You feel tired. You feel like something ain't right. You used to, let's just say, walk up a flight of stairs. Now, by that second step, you holding on to the thing like, Lord, where the escalator, right? Okay? Because you don't have the red blood cells to get to those muscles that you need to, right? So then you go down here to Naomi, and what happens is you bleed a little bit, and then you bruise a little bit, and you're like, Lord, I ain't about hit nothing. Why am I bruising and bleeding all the time? It's because Naomi here is the person that's supposed to stop you from bleeding, and what's happening is that she's not able to do her job because, unfortunately, there's cancer in there. Does that make sense? And so this is why multiple myeloma is a problem, is because these things, if you don't have these three people right here, you ain't going to make it. Right? And so as long as they got space and they can spread out and do what they're supposed to do, then they're good. They can work and do what they're supposed to do. But whenever they get squished, there's a problem. Okay? Y'all can go ahead and sit down. I appreciate y'all. Okay? So now that y'all understand, like, what the cancer is, then the next thing you got to figure out is, like, what do you need to do about it? All right? So if I get my brother right here in the green shirt, brother, you want to come up here for a second? All right. So now, what's your name, brother? Reggie. All right, Reggie, I picked Reggie. Reggie's the biggest brother in here, all right? So what happens is that Reggie can pretty much take care of business and do what he's supposed to do, okay? Now, if Reggie's job, right, is to be one of these white blood cells that should be attacking COVID or the flu or anything else, then Reggie can take care of it. Reggie ain't too much Reggie can't handle. Ain't that right? Right? So what happens is that we had an idea. And we said, well, what if we take a big soldier like Reggie, and instead of him fighting off COVID, just say, Reggie, why you don't fight off cancer? And Reggie was like, well, I don't know how. So we can train Reggie, being the immune system, being the white blood cells, to be able to fight off cancer. All right? You say, well, what does that mean? So what happens is that Reggie has been a soldier his whole life, right? So whenever you have gotten sick, you don't even think about it. You just say, oh, I'll wait a couple days, or you might take a little bit of medicine, and then you get better, because you got soldiers like Reggie that are just ready, looking for the next infection, right? But the problem is that when it comes to cancer, it's walking around Reggie, it's messing with Reggie. Reggie not touching it. And you're like, Reggie, as big as you is, why are you not fighting off this cancer, man? What's going on? Because Reggie can't recognize it. He doesn't understand, because his job is to look at the immune system. If I was COVID, Reggie be 1, 2, 3 looking like Tyson, right? But when you're a cancer cell, it's blind and Reggie can't see it. So what we did as doctors is we had the idea that we can basically open up Reggie's eyes and say, look, you see a bow tie, you take care of it, okay? And so that's the problem, okay? And then I appreciate it, Reggie. Thank you so much. And so, and so that's basically what we did when it came to CAR T-cell therapy. We use, like the pastors tell you this, the way we was beautifully and wonderfully made, I'm telling you, God was looking out for us, okay? Like we already had the machinery inside of us to take care of a lot of these things. We just had to kind of mix it together. So Pastor talked yesterday about how there's always going to be this balance, right? Of like, the doctors and the ministry kind of working together. So you need to say, hey, if God gave us all the tools, you can have a hammer all day. If you don't know what to do with it, that's a problem, right? So we have the tools that were made within our bodies, and we had to just come up with a way to be able to use that to fight off cancer. And so what happens is that what we do, and again, this is something that I do every single day, is that we tell people's immune system to say, hey, you see anything with a bow tie, you see anything that looks like this particular cancer, I need you to go fight it, okay? And that's what is called CAR T cell. The thing is that CAR T cell does have a little bit of side effects, right? Like, I don't want to lie to you, okay? But some of those side effects are things that sometimes tells us that things are working. So for example, if Reggie is a big immune system, right, that he's used to fighting off infection, well, what happens is that he doesn't work alone. He works in an army. So what happens is when he sees something's wrong, he gather all his immune system friends, and they go and they get rid of typically the infection. But now he's getting all his friends together and going to fight off the cancer. So your body thinks that you have pneumonia or the flu or something. But really what's happening is that your immune system is being activated because now you're activating it to fight off cancer. So what happens is that sometimes people get a fever. Sometimes people get chills. Sometimes people like energy will go down, right? As a side effect of these medicines, but really it's just your body being active. Does that make sense? And the immune system cells like Reggie going to work, okay? And so instead of them, again, going to work for the cold or for the flu, they're going to work to kill your cancer cells, okay? Sometimes what also happens is that sometimes people can also get sometimes a little bit of confusion that happens sometimes with these medicines, because what happens is that these cells, because they're your own cells, they go everywhere. And what happens is, again, God made us wonderfully. God likes to protect a lot of the things that are important to us. You say, well, what does that mean, Dr. Blue? Your brain, for example. My mom always said I had a hard head, but what happens is that we have a thick skull that protects a lot of us from having issues. So our brain is very special. So we have a natural protection. Your heart is very important. So you got a big breastbone, right, to make sure that you don't have problems. Your lungs are also super important. So when you take a deep breath, you feel these little notches, those are your ribs. So we have natural protection for the things that are important and vital to us to stay alive. And so what happens is that sometimes when we give these CAR T cells, sometimes what happens is that they can cross a little bit of a barrier, so that sometimes people do get a little bit of the confusion with it. But what happens is it just knows that these cells are going to work and help kill cancer. Now, the good thing about it is that because all we're doing is teaching your own immune system to kill cancer, is that we can also change what we tell Reggie. So for example, we're talking about multiple myeloma, right? And we say, all right, Reggie, anything that has a bow tie is multiple myeloma. We need you to go and kill it. Well, what about lung cancer? We can tell Reggie, say, hey, anything that looks like a lung cancer cell, we need you to go, anything with a blue shirt, I need you to go attack that. So we can use this same technology and just replace the different type of cancer that it is, okay? So right now it's approved for people who have something called leukemia, which is a cancer of, again, that bone marrow. It's also approved for people who have something called lymphoma, which is a cancer of the lymph nodes. So you ever tell anybody and say, oh, my glands is getting enlarged, especially after they had like maybe an infection, or sometimes it happens when women get like a little cut underneath their armpit and you notice that it swells underneath here. Those are your growth. Sometimes even happens in the groin. Sometimes, a lot of times, again, it's from shaving, but those lymph nodes can actually have cancer in them, and that's called lymphoma, all right? And so CAR T cells is approved for that as well. So we keep making more and more different types of cancers, and this is a natural way of us killing it, right? So, whenever somebody thinks about cancer, the next thing they're going to think about is chemo, right? And this is something that's way different than that, because chemo, you get that from a pharmacy, you know what I mean? Like, it's hanging in a bag, and that's not a natural way of killing. I mean, it works, don't get me wrong, but then you have a lot of issues sometimes with chemotherapy because, again, it's not a natural thing. But what we're talking about is using something that you was born with and just telling it to do something different than what it was naturally meant to do. Does that make sense? And so this is a very natural way that we've been able to kill cancer. And again, like I said, it's only really getting started, and we're only going to make it better and better. And the different types of cancer that we can kill, it's only going to get more and more. I'll tell you something even more important. So what happens is that your body is so complex, right? And so what happens is on the cancer cell, right? Let's just take multiple myeloma, for example, okay? It might have a yellow bow tie, a red bow tie, a blue bow tie. And so when we tell Reggie, we say, hey, he looks for this yellow bow tie. And then what happens is the cancer cells get smart. And they say, well, every time we make this yellow bow tie, we got big old Reggie here trying to come and kill us. So what does the cancer do? It makes more cancer cells, but just now with red bow ties instead. So again, so Reggie's coming and he's looking, ready to fight. And then now he don't see him. But what we can do, especially with this new CAR T, is just change the target. And we say, all right, first time we gave you a CAR T, you killed all the yellow bow ties. Now we need you to kill all the red bow ties. And then the cancer cells. And so you look down the road, it might be 20 years. You know what I mean? Because all we've been able to do is just change the different types of bow ties, the different types of receptors that we can tell these cancer cells to go start killing. And we've been seeing some excellent results with it. I will be honest, we have not cured people yet from this disease because, unfortunately, like I said, the cancer cells are smart. So even though you might get this wonderful therapy, CAR T cells, and it typically does work for years, at some point that cancer cell just learns, well, if I change something a little bit differently, Reggie not going to know how to get me. And then we just have to do it again. Does that make sense? So it is something that works really well, but we just haven't figured out how to, like, get it down and keep it down forever. You know, because if I tell you you cured, even if it come back in 10 years, you're going to be looking at me sideways like, Dr. Blue, you told me it was cured, man. What's going on? You know, so I want to just be honest about that, but it is something that we're improving. And this is a new technology, right? This is something that's only been approved over the past couple of years. So we'll figure it out, right? But as of 2025, we haven't figured out the right combination of how to exactly get it down and keep it down forever. But it does typically go down and stay down. And the good thing about it, this is important, you know how, like, typically when you see people, especially on the movies or in TV, when they have chemotherapy, what happens is they have to go to the doctor, like, sometimes 1-2 times a week, sometimes 3 times a week, and they get shot and stuck and poked. Well, after you get this CAR T cells and after Reggie learns how to kill the bow ties and kill that cancer cell, your body is going to take care of the rest. So it's a one-time treatment. So you do it once, and once Reggie learns that, you're good. Right? So instead of going back, there's no going back in infusions and all that kind of stuff because this is your own body. This is your own immune system. So you literally have a living medicine inside of you that will continue to work, continue to do what we call surveillance, meaning that it's looking for all the bow ties, it's checking behind the things, you know what I mean? It's looking for them because it knows what to look for. Okay? And so, you know, I just wanted to come up here and tell you guys about, because a lot of people are not really talking about this. You know what I mean? And this is a cancer that unfortunately disproportionately affects us. And so I want to make sure that as these new treatment comes out, that we're not at the end of the line, right? Like, I want to make sure that somebody like, hey, I heard that you could use my immune, even if you forget the name CAR T, it don't even really matter. But if you remember and say, hey, I think there's a way that you can use my immune system to be able to fight off my cancer, that's a natural way of killing cancer. Can you sign me up for that? Or can you look into that for me, right? And so I just want to make sure that people are educated about it. We're going to talk more about it as far as be happy to answer any questions. But I just want to let y'all know kind of what I do every day. So thank y'all so much.
Dr. Blue, you did that almost the way a surgeon would, so I can't give you any better compliment than that, sir. Well, we heard a little bit about CAR T cell, and you heard Dr. Blue tell us it's kind of a newer kind of treatment. And so, as I said, these things don't develop in a vacuum. There's somebody and there are some people who go about helping us develop these things. Our next speaker is Dr. Leslie Popplewell, and she'll be talking to us about research and clinical trials for treatment of multiple myeloma. Dr. Popplewell is a graduate of the University of Louisville School of Medicine, go Cards, and she did a residency in internal medicine at Temple University in Philadelphia, and a fellowship in medical oncology and hematology at Memorial Sloan Kettering in New York, and her fellowship in bone marrow transplantation at the City of Hope Hospital in Duarte, California. She's currently the medical director of hematology and blood and marrow transplant at the City of Hope Cancer Center down here in Atlanta. And she's also an associate professor in the Department of Hematology and Hematopoietic Cell Transplantation at the City of Hope in Duarte and down here in Atlanta. You do a lot of traveling. But I want to just mention one thing. Dr. Popplewell was asked about taking care of patients, specifically about lymphoma, but I think her answer was germane to taking care of patients with cancer. And her response to me was very interesting, especially coming from a physician. Because she said, patients are never isolated. The family and the friends are involved, and that is important. Kind of like what we heard the other day. That is important because everybody needs help getting through a serious illness. Everybody needs help. And I think that kind of speaks to the quality of the folks we have here today. So I give you Dr. Leslie Popplewell. Thank you very much.
Okay. Oh, thank you. All right. Well, good morning, everybody. Thank you so much for your attention. I appreciate that. Thank you, Dr. Blue. That was a wonderful rundown of CAR T-cell therapy, and absolutely, it's been my privilege over the last 20 so years to help introduce patients to new kinds of treatments that weren't available when I started my education. So clinical trials are the way that we bring new treatments to patients and their families. So I think I've got a few clinical, a few slides. These are not them.
Push it down to advance.
Oh, okay. I'm going down to advance. Okay, all right, it's like TikTok. So I have a lot of slides. I'm not gonna adhere to this very much. I just wanna make sure that they guide me a little bit. So clinical trials are the way that we bring new treatments to patients. Clinical trials are available at a number of sites. A lot of them are academic medical centers, but increasingly there are clinical trials that are expanding into the community as well. And our job is to work with the patients as well as their primary oncologists who often will refer patients to us. We're trying to answer important scientific questions. Our goal is to take treatments that started as a concept in the lab and to take them out to patients in the community. And we do that in a stepwise fashion. And so typically when a new cancer drug becomes available, we start treating patients who have run out of some of the normal options that they have. So patients who have maybe gone through a few different lines of chemotherapy or other treatments, they don't have a lot of other options, they may come and look for a new kind of therapy, a new concept. As we get more comfortable and learn more about those treatments, we start saying, wow, this is really a great treatment. Let's take this a little bit sooner. Let's not restrict it to patients who have had a lot of lines of therapy. Maybe it'll work even better if we start treatment early on. And so the treatments like CAR T cells that started out only for patients who have run out of other options are now available in a second line setting for patients with multiple myeloma. So you have one line of therapy, maybe you have a relapse after that and it doesn't work, now you can have your CAR T cells. You don't have to wait to go through a lot of other things that might not work as well. As far as cancer clinical trials, so we've talked already about how many patients in the United States are affected with cancer. Right now, only about 3 to 5% of patients with cancer are treated on clinical trials in the United States. And I'm talking about adults, right? So grown-ups don't participate in clinical trials very long. Pediatric cancer, thank goodness, very few children are afflicted with cancer, but pediatricians realized early on that if they were going to make any progress treating pediatric cancers, they really needed to do more research. And so it's true even today that the majority, more than half of children affected with cancer in the United States are treated as part of clinical trials. And that's why the survival rate for children afflicted with cancer has really skyrocketed. We've really gotten much, much better at treating children with cancer. And that's becoming more the case as well with adults with cancer. But we still think we have a long way to go in terms of introducing adults to clinical trials. So as far as clinical trials go, we have a variety. We have treatment trials, and those are the ones that I participate in most often. Prevention trials, how do we prevent cancer from starting? That's an answer we would love to have. We don't have the answer yet, but there are a lot of interventions that are being tried for patients who are at high risk for cancer to try and intervene early and prevent that from happening. We have early detection trials, screening trials. So now we have screening for lung cancer for patients who are at high risk. We have diagnostic trials, and we have quality of life studies as well. So we talked a little bit about the different phases of trials. Phase 1 trials are where we really have a brand new treatment. We've identified a problem, we've identified a mechanism, we're having some good success in the lab, but now we need to try and bring that to patients. And so phase 1 trials are the earliest trials where patients are really getting a new treatment. So with phase 1 trials, we usually will do a stepwise treatment. So we'll treat patients with a very low dose of the new drug. The next group of patients will get a higher dose of the drug, and so on until we're at a dose that we think is both well tolerated and where we're starting to get some response signals. So phase 1 trials are things that people have varying degrees of comfort with. We're learning a lot about the drug. We don't always know exactly how people will respond. Usually there have been animal studies where we get some signals, but people are not mice, right? And we know that. After a phase 1 trial, we go to phase 2 trials. Phase 2 trials are where we've been through a phase 1. We've already identified that there are some good response signals going on. We think it's going to be a successful drug. We think it's going to help a lot of people. What we say is with that, let's take a whole group of people, let's give all of them the same good dose of the drug that seemed to be working in phase 1, and let's give all of the patients the same drug, the same schedule, and let's see how they do. And after that, now we've got an idea. Now we say this percentage of patients is going to respond to this treatment. After phase 2, then we go on to phase 3, and now we say, well, we've got this new treatment, we know how well it works, we know it works in a lot of people. Does it work better than what we have already? Let's compare this to another treatment that we were already using pretty heavily. And so phase 3 trials are where you're getting an option. You can be getting the new treatment, or you might get the treatment that we already know and are comfortable with, and we know how it works. So when you are talking about a clinical trial with your consultant, with your clinical trial specialist, you want to ask questions like that. Well, what is this new drug? How is it different from the drugs that are available to me in my primary oncologist's office? What phase of the trial is this? How many people are going to be on this trial? How many cycles of this am I going to receive? How am I going to feel? So the risks and the benefits are important to discuss. A lot of trials that I'm going to talk about include randomization. So especially those phase 3 trials where you have 2 different treatments that are being compared to one another. A lot of times we don't let the doctor pick what you get, and we don't let the patient pick what they get. It's a randomized trial. And so when you're going into it, you know that you might get treatment A or treatment B. If you have a randomized trial, it's important to ask, is there a crossover portion to this trial? If I'm getting treatment A and it's not working for me, can I switch to treatment B? And a lot of randomized clinical trials have a crossover option for that. So that's important to know about. When we randomize patients to trials, we've got, let's say we have 100 people, we're going to randomize them into 2 groups. We want to make sure, we don't want all older people in one group, all younger people in another. We don't want all men in one group and a lot of women in the other. We want a good cross-section of people. So it's important to know about how people respond. Randomization is important because it helps us understand how different kinds of people will respond to treatment. So clinical trials, we talked a little bit about phase 1, 2, and 3. I will say, so people ask a lot when they come in and we start talking about trials, am I going to get a real drug, or am I going to get like a sugar pill, or am I going to get something that's not effective? Very few clinical trials these days for cancer include things like placebos. Some of those will include some of those prevention trials, like I talked about. But if there is a placebo involved in a clinical trial, the researcher is obligated to discuss that with you. You need to understand if you're going to be randomized, what's the chance that I'm going to get treatment A or treatment B? You know, is it a 2-to-1 randomization? Is it a 1-to-1 randomization? So it's important to know about that. Cancer prevention trials, as I mentioned, those often involve things like dietary changes, supplement additions like minerals or vitamins. It might include dietary changes. It might include levels of physical activity. So those are the kind of cancer prevention trials that we're seeing a lot of these days. And then chemo prevention trials. There are some chemotherapy drugs that are so effective for cancer patients, and they're so well tolerated that sometimes we are using those drugs to try to prevent a cancer from happening in a patient who has a very high risk of getting that cancer. Clinical trial protocols. So, you know, what happens if you talk about a clinical trial? It sounds like a good option. How do things work behind the scenes? So, if you're a cancer research doctor, like Dr. Blue, you have a clinical trial protocol. And so when you're given your consent form to read over and make a decision, those have gotten pretty long, right? Because there are a lot of ins and outs to cancer trials. So your consent form that you read might be 20 pages long. The clinical trial that talks about how we have to act when we take care of patients is probably about 100, 150 pages long, and they're getting longer and longer. And it governs everything about how we conduct the trial. What kind of patient is eligible for the trial? How is the treatment given? What's the schedule? How do we deal with toxicities or adverse events when those occur? So those are all very carefully spelled out. There are groups of committees that will take a look at us and make sure that we're doing all the things that we said we were going to do when we started the clinical trial. They're saying, you know, are we following the treatment plan? Benefits of participation for clinical trials include getting access to more new advanced treatments. It also includes maybe being part of a trial where you are more carefully monitored. I will say that patients who are on clinical trials usually get more scans, more lab draws. They have a little bit more visits to the doctor. So I tell people it may be a little bit more of a time obligation for you, but if you're getting a new treatment that might be more effective, that may make it more worthwhile for you. So you have to make that decision for yourself, and it's the job of the person who's conducting the trial to answer all of your questions to make sure that you're making the best decision for yourself. Risks of participation, well, some of these are newer drugs. So when I started giving CAR T cells, they weren't yet FDA approved. And it was a little bit of an adventure. We take care of CAR T cell patients differently now than we used to. Because the toxicities that are associated with CAR T cells are different than the toxicities for chemotherapy, right? And so there are fevers. When the immune system wakes up, it starts to do things. And so when the CAR T cell recognizes its target, it'll wake up and make the patient feel like they have the flu. But in the meantime, they might also get low blood pressure. They might also get some confusion. And so we have gotten much better over the years at dealing with that. But when you're in a clinical trial, these are new treatments. And so we might not always be able to anticipate. So there are things that have happened in terms of how we anticipate and prevent some of those side effects now. Patient protection. So we talked a little bit about some of the committees that exist to keep the researchers on track. Those are protections that are in place for patients. And so when you get into a clinical trial, you want to know the ins and outs. You want to know what's going to happen if I get a toxicity. What's going to happen later if I decide I don't really want to be a part of this trial anymore. So it's important to remember that clinical trial participation is always voluntary. You are entitled to as much information as you need to make the best decision for you. And consent is an ongoing process, right? And so You consent every time you go in to get that next treatment, to get that next blood draw, to get that next infusion. And it's your right to change your mind at any point. So don't ever feel like you're locked into something just because you signed a piece of paper and agreed. How are patients' rights protected? So we talked about informed consent, and that's an important part of the initial clinical trial. There's also scientific review, and so even before the trial is open, there are committees that have reviewed it who have said, yes, this is a valid question to answer, yes, this is a valid treatment, it's promising enough that it's worthwhile to take to new patients, and once the trial is underway, there are data and safety monitoring committees that will review on a regular basis and say, yes, I think that this researcher is doing what they said they were going to do. If there are deviations, then those are reviewed. So if there's a patient who came in and we thought they were eligible, but it turned out that one of their blood tests made them ineligible, that's evaluated. So we all have to kind of follow the rules that we set, and we set an awful lot of rules when we start doing clinical research. Why do so few cancer patients participate in clinical trials? Well, part of it might be reluctance on the part of the patient. There's a lot to be examined when you are thinking about doing something new and different. Some of the cancer trial participation might involve meeting a new medical team or going to a new cancer center. And so that's a barrier. People don't always want to travel an extra hour to get treatment, and they trust their primary oncologist. Research institutions need to work in conjunction with your primary oncologist to make sure that everybody who's involved understands what is going on, because clinical trial participation is usually not forever. Eventually, you may finish that treatment. You may have a great outcome and not need treatment anymore, but your primary oncologist is still going to be there, and they're going to be there in your backyard to help take care of you. So we all have to work together. Doctors might lack awareness of appropriate clinical trials. So it's nice to know that there are places where you can go and say, look, I'm at this point in my cancer care journey. Are there clinical trials around that I might have access to? And so clinicaltrials.gov is a great website that you can go to ask questions like that. What are the clinical trials available in my area? There are professional societies like the Leukemia and Lymphoma Society, which is also a myeloma concern. The Multiple Myeloma Research Consortium is also another organization that has a lot of interest in making sure that people are aware of what kind of clinical trials are available for them. And most cancer care centers like to have a wide range of trials that are available. So a patient walks in who has a newly diagnosed disease, there may be one trial for those patients. A patient who's had one relapse, there might be a different set of trials that are available, or a patient who has had multiple relapses in the past. And so, again, I'm just going to emphasize that the things that we are able to do right now are not things that we really were thinking very much about doing. They weren't even like the twinkle in the eye of a researcher when I was a fellow, but they're the reality now. And 20 years from now, we will have an entirely new landscape for how we treat multiple myeloma. And that's what's really exciting about participating in clinical trials. And so I hope that you'll consider it, or at least make plans and look into what's available to you. And our goal as research institutions is to work very closely with physicians in the community and with patients so that everybody is on the same page and understands what the risks and benefits are. That, I think, is all I have.
That's all. That was a lot. Thank you very much. Thank you very much, Dr. Popplewell. Appreciate that. One of the things we talked about yesterday, we mentioned that multiple myeloma affects 1% of the population. And we think, but do I really know anybody? And we heard yesterday the Price family, melanoma, but we also talked about a couple of celebrities with melanoma. Tom Brokaw, he used to be anchor for NBC News. Some of us of a certain vintage may remember that. And then, though, for other folks, there was the rapper Guru out of New York. and also Ice-T. I think he crosses generations. But it does affect our various family members. Our next person wasn't able to be with us today because she unfortunately has to attend the funeral of an uncle. But Ms. Kim Lindsay was able to film a video for us to discuss what it was like for her caring for a loved one with multiple myeloma while managing self-care. She's going to discuss for us the journey of the caregiver and the patient doing CAR T-cell therapy, lifestyle support and care strategies, and the thing that some of us, we sometimes forget, but we'll hear from our next two speakers, that thing of the burden, the caregiver burden. Does the burnout emotionally, physically, and financially? But she's going to kind of lead us. So we're going to have that video now of Miss Kim Lindsay.
Hi there, my name is Kim Lindsay and I am the daughter and caregiver of Jenny Walker. I want to spend some time today talking with you about what it means to be a caregiver for a loved one with multiple myeloma while really managing my own self-care. But before I jump in, I just want to start by saying a heartfelt thank you to Heal Collaborative for really providing a space where the community, caregivers, and patients can come together and leverage one another, really lean on one another for support and to help us navigate what can be a very challenging time. So thought it wouldn't be right to just dive in without first saying thank you for providing the space for me to share my mother's story of triumph. And I'm so proud to share it with you and honored to be a part of the conversation, really. So what I intend to talk to you about today, I'll begin by talking to you a little bit about what our journey looked like. I'll share a little bit about my mom, and then really want to talk a little bit about lifestyle support, really different strategies and tools that I leveraged in order to navigate going through CAR T-cell therapy with my mom. And then also want to talk to you a little bit about, I guess some people would call it the caregiver burden. I prefer to think of it as like the impact that being a caregiver has on your life, because when I think about my mom, I can't ever put the word burden in the same sentence because you know, I serve her with all of my heart, and I also want to leave space to acknowledge that what she was going through was far more challenging than what I was going through as a caregiver. However, there were stress points. There was financial and emotional stress, and really it was important for me to be intentional about how I was going to manage both the financial and emotional stress so that I could show up and be better for my mom. So talk a little bit about those points, but first I have to tell you about my mom, my phenomenal mother, Jenny Walker. So in 2013, we went to Jamaica to celebrate her birthday. And during that trip, she was going through some excruciating back pain. And I can remember all of us feeling like something is terribly wrong. We didn't know what, but we knew that something was terribly wrong. And so when we returned back to the States, shortly thereafter, in 2014, my mom received the diagnosis of stage 4 multiple myeloma. Since then, she has been through 2 stem cell transplants and just recently successfully completed her CAR T-cell transplant. So she just graduated from the program, and we are so excited that we really had very little complications. She did not experience any neurotoxicity. She did not experience CRS or cytokine release syndrome, really no infusion reactions. And so we were very fortunate. We actually had, I know this sounds very strange, but we had quite a beautiful experience spending a lot of time together and bonding. There were some challenging moments, but for the most part, I think we were able to really just leverage our support system and leverage a lot of different tools in order to make the best of our situation. When I think about some of the different tools that helped me, there were really quite a few different things that helped for us. When I think about the difference also between what we went through with the stem cell transplant and then now the CAR T cell therapy, I said to myself, what am I going to do differently? And the first thing that I did differently, I'm almost embarrassed to say, but I decided to read the caregiver handbook. I'm embarrassed to say that I went through 2 stem cell transplants without reading the caregiver handbook, but I just want to be forthcoming. So anyway, this time I decided, what will I do differently? I will begin by reading the handbook. And something that stood out to me immediately was there was a moment in the book where they said you really should create a support system for you, for yourself as a caregiver. And I thought to myself, okay, this is going to be the biggest thing that I do differently. I will create a support system. So my family and I, we're from Jamaica. We are Jamaican and American, but my mom is a proud, strong Jamaican woman who is also very, very private. So when we went through the 2 stem cell transplants, she really wanted for me not to tell very many people. My husband knew, my sister knew, but there really wasn't a group of people supporting us. I had a few aunts who were aware of what was going on, but for the most part, we kind of went through it by ourselves. And this made it quite challenging. By the time we got to the CAR T cell therapy, she and I had some difficult conversations, and the one that stands out to me was I had to say to my mom, Mom, if you will allow me to share this diagnosis with a small group of people that you trust, like we can really decide together who you would like to tell, it's going to make it easier for me to support you. And I really felt I needed that additional support this time around. And so my mother lovingly told me that she really didn't want me to have to go through a more challenging time than was necessary. And if that's what we needed to do in order to make things easier, she gave me her blessing to share with a very small group of people. This was huge for me. This group of people, they were an extra set of eyes for me. They were the people that I could call when I needed a break, when I was feeling overwhelmed, when I needed someone to come and sit with my mother for a few minutes. This group that we created, they really helped me to navigate and gave me the necessary breaks that I needed. We created a WhatsApp chat. They also helped me to keep an eye on her meds. I knew that the medicine was critically important, and so I had leveraged a lot of my corporate skills. I was using calendar invites, I was using Alexa, I was using Siri, I was using all of these different kinds of technology to make sure that I stayed on top of her medication, that I got it to her when I should. But let's be honest, there are days when you're exhausted, you think you've got it under control, but you're tired and you're wondering, did I miss something? So what I did was I created a WhatsApp chat and I shared her med list in the WhatsApp chat. And so I had this group of people who would say to me, did you remember to give her this one? Did you remember this medicine stops today? It was extremely helpful to know that it wasn't all on my shoulders. And I think that all of these tools together helped me to really be sure that I stayed on top of her medicine and she took it exactly the way that she was intended to take it. The other thing that I will say about that is I also really leveraged the hospital. Whenever I had a question, I called. If it was day or night, I called. If it seemed like a silly question, I called. I mean, there were so many times where one night she had missed a med, I remember, and I thought to myself, is it okay for her to just skip it and take the next dose, or does she double up in the morning? I called them. Literally, there was no question too small that could prevent me from calling to get clarity. And I wasn't embarrassed or ashamed. I would even call sometimes if I didn't understand what to expect next, or if I was confused about something, I would ask them to tell me again. So I really had no shame. Sometimes the nurses would come in and have an additional consultation with me because they had it with me, but I really felt I didn't remember and I wanted to hear it again to make sure that I was clear. I remember kind of like repeating back every protocol to them and really trying to be so much on top of it that I knew what to expect next, almost with my eyes closed. I really wanted to make sure that my mom didn't have to feel any of the stress of remembering what's going to happen next or remembering what we needed to do next. So these were all quite helpful tools. The other thing is, quite frankly, we made great friends with the nurses and the medical professionals that were caring for my mother. We felt, okay, number one, we're seeing this group of people every single day. And number two, we really felt that we wanted to know about them. We knew the names of their children. We knew the names of their family. We knew what they were doing for the weekend. And I think this connection on the human level really also helped them to give us an extra discretionary effort. I really felt that the people caring for my mom were treating her like they were caring for their own family. And I think it could be because we felt very close to them and they felt very close to us. We also, I had created this lovely video of all of the people that my mom loves, and I wanted to remind her of what she was fighting for. And I can remember playing this movie on the iPad and people coming over and saying, "Is that your grandbaby?" People would come over and say, "Is that your grandbaby? Is that your son-in-law? Who are these people?" And I felt that because they knew who we were and because we knew who they were, they really treated us like family, and that made all the difference. I can remember one particular incident where there was a nurse named Kate who, we were always very punctual. And this morning in particular, we happened to be 5 minutes late, and the commute had taken us longer than 2 hours. And suddenly we shared with Kate that, "Oh dear Kate, we're sorry we're late, but the commute today was horrible and it took us 2 hours." And suddenly Kate said to us, "2 hours to get here?" She said, "That's just too much, especially when there may be times when you need life-saving care. You can't wait to get here for 2 hours." And literally within minutes, Kate arranged for someone to call us, and they found an apartment that was 5 minutes from the hospital. We actually called it the resort because it was so lovely. And also my mom really wanted to not feel like she was sick. So we called it the resort to kind of make her feel like she was on holidays. But anyway, Kate made the arrangements for us to have this space. Our commute was 5 minutes, so we didn't have to think about nausea while driving in. All of these, to her it seemed like such a small thing, but it changed what we were going through exponentially. And also they found us a program that would help to pay for food. They paid for food for both the caregiver and the patient for about 2 months. They were paying. And so if I can give any advice, I will say there are grants, there are people who will help. I really encourage you to leverage the professionals around you and ask them, isn't there somebody who can help us? Are there any things that I'm missing? I think that particularly when you're in connection with a lot of your medical professionals, they want to help you. They want you to be victorious, and so they're willing to share the information. I think sometimes it's just about asking the right questions and really leaning into your own curiosity. The other thing I will say, this is going to sound a bit silly, but I love to play the piano, and one of my vices was playing instruments. So I actually purchased a xylophone, and when I felt I needed a break or I felt I was overwhelmed, I would sit and play. I scheduled time for myself where I knew I would be able to play, and this kind of helped me to refill my cup, to escape for a little bit, to really not be so serious all the time. I'm banging away on the xylophone, and it may seem silly, but I needed something that sparked joy for me, that made me happy so that I could show up as my best self for my mom. And that outlet really helped me. Learning a new instrument really helped me. It may sound strange that I was able to find time to do that while going through all of this, but I think it was about like doing it while mom was sleeping or taking 10 minutes here and there. And it was just really about taking 10 minutes for myself. I am thankful for the group of people that were supporting me, my husband, my family, the network of people that we had created. But I also knew that I had to pour into myself, and music is just one of the ways that I was able to do that. The other thing that I want to really speak about is really being intentional about mindset. My mom and I also spent a lot of time laughing, dancing, giggling, putting on lipstick, doing silly things that seem maybe a bit strange for somebody who's going through CAR T-cell therapy. But for me, my mom made it abundantly clear that she did not want to feel sick. She wanted to feel joy. She really was very clear about wanting to be happy while she was going through this CAR T-cell therapy experience. And we were intentional about removing stress. We didn't watch any sad movies. We didn't watch anything stressful. We only listened to uplifting music. Darling, we're from Jamaica, so there was a lot of reggae and a lot of dancing and laughter, joy, comedies. And I think when you start out with this triumphant mindset, this really, we decided we were going to win. I think it made all the difference. And I'm sure people say that to you all the time, but mindset for us really did make a huge difference. My mom did not experience any of the things that they said she would. No neurotoxicity, no CRS, no reactions. And I really think it's because she was so strong mentally. We were both locked in together, and I think this made a huge impact. The other thing that I will say when it comes to emotional and financial stress, there was a time where I realized that I wasn't able to do my job well for my mom while working a full-time corporate job. And so I'm fortunate enough to have been able to step away and say, I'm just going to focus fully on my mom's care, even if there is going to be a financial impact in my household. And my husband supported me. I have a 2-year-old who goes to private school, so this was really a difficult decision. But for me, it was about what can I eliminate? What can I not spend money on so that I can really take this time to be with my mom, and really having the time to dedicate to my mom fully. I know that I was better for her this time around, particularly because I was 100% focused on her joy, on her care, on ensuring that she got the life-saving medicine that she needed. And really, it made a tremendous difference. I know that everybody's not able to do that, but I will say that if you're not able to do that, the other thing that could be quite helpful, that was helpful for me even initially, was just sharing at work with my colleagues what I was going through, and telling them what I needed in order to feel supported, and letting them know that, normally I work on weekends, can't do it anymore. I need to be focused on my mom. And so I think just having that open communication really made a huge difference. And also I think, normally I'm very private at work, but I think it was a moment where I kind of had to put my pride aside, be a bit more open, and talk to the people around me about what I need. So I guess if I had to put everything into a synopsis, I would say there were 3 things that really impacted my mom's care. The one was the intentional decision to use joy as a strategic tool to get us through a very challenging time. We were intentional about finding moments that would make us happy. Even little silly things like inviting my daughter to the resort to ride her little tricycle outside so we could giggle and laugh, blowing bubbles with her. So joy as a strategic tool was probably the hugest thing, I would say, and really focusing on not just her mindset, but my mindset. The other thing I will say is leaning into curiosity, asking 10 million questions if you need to until you're absolutely 100% clear, and not walking away from any meeting with any doctor or any medical professional unclear about what it is that needs to happen. And then last was really that moment where I read the handbook and I realized I needed a team of people around me to support me. And, I think that also helped because I didn't have to bear the load by myself. And I'm so thankful to share my mother's story. She's extremely active. She's back to playing pickleball, playing Zumba. She goes to line dancing classes. She's back to her normal life, and we both couldn't be happier. And so I wish all of you, both patients and caregivers, much success. And again, thank you to Heal Collaborative for allowing me to share my story. It means so much to me. Cheers to you. And cheers.
I think that we can all agree that what Ms. Lindsay was saying, not only is it applicable to the patients with multiple myeloma, but taking care of patients with many chronic illnesses, not to mention just cancers. How many people here are members of Shaw Temple African Methodist Episcopal Zion Church? Show you, raise your hand. Okay, good number, good number. More importantly, is the number of people who didn't raise their hands. I don't know how many of you remember from yesterday when Reverend Morrison said that not only is his church is about community, not just the community of Shaw, but also the community where Shaw exists. And so I want to compliment you again for being open to allow people to come in and hear messages. Congratulations to you, sir. And thank you. On your tables, there's an interesting little booklet. This is not the caregiver manual, but it tells a lot about patient education regarding multiple myeloma. And I think it's a good thing to take home, because you hear a lot of the things we're talking about today are going to be mentioned in this. Our next speaker is Dr. Christy Donovan, and she'll be speaking to us about patient navigation and supporting the whole family. Now, I got to tell you, we're shifting gears a little bit. So the next two people, Ms. Mathis and Dr. Donovan, are kind of getting to the crux of the thing. What do you do when you're handling this situation? Currently, Dr. Donovan is the blood cancer coordinator for the Blood and Marrow Transplant Leukemia Program at Northside Hospital Cancer Institute. She is a graduate of the Medical College of Georgia, where she got her RN degree, and she received her Doctor of Nurse Practitioner from the University of Alabama in Birmingham. Now, the thing about where she is right now is kind of talking about people who need services. And when you need services, you need services. You don't need somebody pointing, well, go down here, do this, turn the corner, go around there. Her goal has been to streamline diagnostic workup, provide patient support and education, and help facilitate referrals within the Northside Hospital Cancer Institute. And if you all try to get around, I used to joke with Ms. Mathis, I oftentimes can't go from a parking lot to the radiology department. I don't think I'm the only one that's GPS challenged. But these are the folks that help us get around. So to help us talk about patient navigation, Dr. Christy Donovan. Thank you.
Whoa. That's okay. Hello, I'm loud, so if I'm too loud, I'll put this mic down. So thank you, Dr. Tuckson, and for the HEAL program. This is a great opportunity. I appreciate you guys having me here. Thank you for sharing your Saturday with us, and hopefully you learn a thing or two out of this. Okay, let's see if I get this right. Nope. Nope. This is the down button. Well, we'll start here. Okay, I got it. So empowering you. So today is about you as a caregiver, as a patient. So I think everybody in this room is probably at a different point in your journey right now. But I think that if you share your story with those around you, I think that you will realize that you're fighting battles that a lot of people in this room are fighting. So what I say is that the first step is showing up. You guys are here today, you've done that. But keep showing up. Show up to that doctor's appointment. Show up to that bone marrow biopsy that you don't want to have. Show up to the first day of chemotherapy. And keep showing up. Show up scared. Show up confused. Show up even though you have no idea why you're there, but somebody told you to be there. I think we're all a mess, right? We don't expect that you have all those pieces, but show up and let us help you put those pieces together. So treatment planning. So multiple myeloma is not a one-size-fits-all. There's a lot of factors. There's a lot of different treatments, thankfully. There's a lot of factors that go into what your treatment journey is going to look like. And so I think because of this, trusting your healthcare team and finding a team that you trust, even if it takes some time, is crucial. So we want to know what's important to you, right? What's your quality of life look like? What are your challenges? What are your financial barriers? How far away are you from the clinic? Can you drive? Do you have people that can drive you? What's important to you? What's your medical history look like? So all of these factors are going to come into play when determining what best treatment options are for you. Dr. Blue mentioned this earlier, but currently multiple myeloma is not a curable diagnosis, but we say highly treatable. And what that means is we have a lot of tools in our toolbox, right? But you have to show up to let us use those. So it's treated more of a chronic condition. So to stay consistent, to have your people, to take your medication and to go to your appointments to help you have the best outcomes as possible. We know that you're going to have bad days, and the hope is you have more good than bad. But on those bad days, these are the people that are going to get you through that, right? Hey, you didn't go to your doctor's appointment today. Hey, you don't look so good. Hey, why are you not taking your Revlimid or your nausea medicine, right? So that's going to be what's going to keep you going. So goals of treatment. So from a healthcare standpoint, goals of treatment, right, are we want to improve your symptoms. We want to slow these myeloma cells down, and we want to keep them as quiet as they can be for as long as possible. So what that looks like is reducing that bone pain, right? You're not aching, your bones don't hurt, your kidneys are improving. You have that energy to get up the stairs, like Dr. Blue said, that fatigue is improved. And then we talk about remission, right? So we want the longest period of remission. And we also want to give you the tools to not live in fear, right? So when we get you into that remission and those cells, those cancer cells are quiet, how do you not live in fear? How are you confident to know what to expect and what it might look like if it returns? So I think that's, again, a big piece of the bigger journey. So common barriers to care, financial toxicity. There are resources. Ask. Use the resources. Have people look at grants, financial aid. Don't let that be a deterrent to go ahead and seek help. Geographic barriers, I think with community oncology, we're talking about this, that hopefully access to care is improving, so you're not driving 2 hours one way to get treatment weekly or multiple times a week. Language and healthcare literacy. So I think multiple myeloma is a very difficult diagnosis to explain, even to healthcare. So when I'm educating my nurses who are oncology nurses who see this, it's a very hard disease to dive into, and they're around this every day. So you take somebody who's not around this every day and you try to explain light chains or an M spike or an SPEP, and they have no idea what you're talking about. So I think that's where we as healthcare members can do a better job to meet you where you're at your education level and explain to you what's about to happen. Emotional distress and then social isolation. So again, I can't expect you to talk to your spouse or your loved one, your child, your cousins, and explain your disease if you don't understand it yourself. So again, the education piece of that. Supporting the whole family. Again, this affects everybody, right? You need your people. And so when I'm explaining to caregivers, you have to take care of yourself in order to take care of the patient and your loved one who's going through it. So what is patient navigation? I think different centers use this differently, but big picture, it's just that. It's connecting you with the resources that are available. You have enough going on. It's somebody to ask the questions that you don't think to ask, right? To get you empowered and in control of your care and to where you need to be. So I think a lot of centers look very similar with Northside. So this is the team that I know. Northside has a lot of community oncologists. And then more specifically, we talked about CAR T therapy. So for example, if you're going to go to the blood and marrow transplant specialist for CAR T therapy, this is their team. So this is not even including the outside community oncologists. But this is to show you that it takes a team not only at home, but also your healthcare team. So you're not going in for just a doctor, but you're seeing the social worker, the psychologist, the nurse coordinators, financial advocates. So it takes a village, both at home and in the office. So if you were to go for a CAR T consult, you are going to see, at least within the Northside system, and I would assume most centers, you're going to see a physician, an APP, which is a nurse practitioner, or an advanced practice nurse, and a clinical psychologist. And this is to look for holes in your plan, right? To look for where do you need the support? Who are your caregivers? Who are your people? What financial barriers do you have? Come in, to ensure that you're coming in without all of the answers, but we're helping you get there. So again, similar, specific to CAR T, this is what an assessment is going to look like. You're going to see a lot of different people in a lot of different areas, financial coordinators, nurse coordinators that are going to walk you through, and like Ms. Lindsay said, the caregiver booklet, this huge booklet of information that we're giving, not the patient, but you as a caregiver to help you get everybody through this process. And then identifying patient needs. So as a team, with all the people in the first slide within the Northside CAR T program, they are meeting weekly and daily. They're asking their nurse coordinators, the chair nurses, the advanced practice nurses, what barriers are you seeing with this patient and what hiccups are we going to have? How are we going to get this patient through safely? And then of course we always rely on other support. So groups like the HEAL program, like the Leukemia Lymphoma Society, we have a cancer support community, BMT InfoNet. So there's a lot of national outside resources as well that we work very closely with, again, to ask for these resources. This is a slide that I share with my nurses. So just so you know, these are the conversations that are going on behind the scenes. So right, again, how do we help you guys? And it goes back to the education and the advocacy, right? The education has to be there. But then at the same time, we have to empower you to ask those questions, to trust us, and your healthcare team to say that these are my barriers. This is why I'm not showing up. This is why I'm not taking my medication, because we can help you. And then I think compliance, oral medication adherence. So that is just that. So there are times that you may not be seen weekly or every other week, but you are on medication at home. And so we want to ensure that there's a good relationship and communication there, that you're taking that medication to have the best outcomes possible. And then survivorship. So again, we want to make sure you've gone through your treatment, you're doing well. How do you not live in fear, right? How do we give you the confidence to get back to your life, knowing that, you're confident in what it might look like if it comes back, and if it does come back, that there's hope for more treatment. So final thoughts, I think patient navigation, and again, the more resources that we have in the community, the better. Patient support, we know that supporting the whole family does improve outcomes, right? This is not just the patient, this is everybody, this is the community. Multidisciplinary teams, again, it takes a village at home and in the community. And then I think just recognizing that we're not just treating numbers in labs here, we're treating the whole person. So what's important to you? So I would encourage you guys today to have those conversations, right? Speak up, find people that are going through the same things that you guys are going through. And that's it.
For those of you that came in during the course of the program, I want to remind you that in the pamphlets that you received, you'll see a survey. There's a pre and a post survey. So if you'd be kind enough to make sure you fill out that pre-survey, and then at the end of the program, you fill out the post survey, and we'll be collecting those. So just want to make mention of that. Our next speaker is Ms. Ursula Mathis, and she'll be talking to us about self-advocacy, something we've been hearing about during the course of this morning. Ms. Mathis received her bachelor's degree in biology from Florida Memorial University and a master's of business administration at the American Intercontinental University. She is currently the vice president of operations for the physicians practice group at Phoebe Putney Health System. Prior to that, however, she was the director of the oncology service line, also at Phoebe Putney Health System. Of note, it's always good to get recognized for being good at something that you do by your colleagues. They oftentimes, when you're real good at something, they give you tasks to do. So I guess you must be doing a good job, Ms. Mathis, because she is also now the co-chair of the Georgia Society of Clinical Oncologists Administrators Association. So not that you had enough to do, you got even more stuff to do. So Ms. Mathis is going to come up here and tell us about self-advocacy. And I want to hear how you tell us who are shy and don't want to challenge physicians and these white coats and all that stuff. How do we go up there and say, wait a minute, you're not addressing my needs? Thank you, Ursula.
Jackson. Good afternoon. As in my introduction, I am Ursula Mathis, and I'm so grateful to be here for today. I'm overwhelmed with the response. I'm thankful for my Hill family. I'm glad to be back with you guys. I've been on a brief hiatus, but I'm back. But this is awesome. We've had a host of good information, and I hope that we've taken it all in. It is so profound to get this level of education to come into our communities. So I hope that we don't take that for granted. But what I want to stop and kind of talk to you all about, I'm going to briefly talk a little about navigation. Christy did an excellent job with explaining navigation, but I just want to bring it home for you. And then I'm going to talk a little bit about this self-advocacy piece, because progress, help, change starts with us. Starts within. We have to, first of all, acknowledge and take steps to make improvements and modifications for us. Okay? So when it comes to patient navigation, as Christy stated, it's your healthcare team, your resources that you have once you've been diagnosed or once you go to your healthcare providers, and they kind of walk you through the process. I always say that navigation is like your GPS, like Dr. Texan said. It's your roadmap. So you get your diagnosis, you got your care team, you're going to meet with your social workers, you meet with your navigations, your resources and everything. They say you got to have this scan done. I'm about to tell y'all stuff. I'm a mover, so let me just get from behind here. They say that you got to have this test done, you got to have that test done, and then you get home with your book and your pamphlet and all these appointments, and you're like, what? I'm just overwhelmed. I don't remember half of this. They start talking, and I blanked out. I'm at a loss. So I go to get my test done, and I'm in the wrong space. They said my appointment was really at 9 o'clock because I had to have labs first and then come back over here at 10 o'clock. They said I wasn't supposed to eat, and I had breakfast. I missed all of that in the conversation. I missed all of that. But this team, this navigation team, comes behind you in that doctor's appointment. The appointment is so much bigger than the meeting with the doctor. And I think we as healthcare leaders and providers have realized that 15, 20, 30 minutes you get with the doctor is a small fraction of what you need from us as a healthcare team. You need someone to interpret what the doctor said, to put in layman's terms for you, to ask you if you have any other questions that you were intimidated, didn't think about, just lost for words, and didn't get the opportunity to ask the physician. Ask if you have any barriers to get into these appointments. Are there any barriers with transportation? Do you have a support system? Is there someone we need to call? Do we need to have a family meeting so we can have this conversation and everybody can hear it and ask questions? This is all things that can't necessarily happen at that physician visit with the doctor, but in the afterwards. This team of navigation, this team that you can create in your healthcare environment that is there for you, makes these appointments for you. We'll meet you there at that appointment. We'll make sure that you know where to go, when to go, and how to get there. Our navigators meet them when they walk in the door. How awesome is that? We have weekly, multidisciplinary tumor boards. And what that just basically means is that all of our doctors get in one room and talk about all of these cases before they ever even see the patient. They talk about what's the latest in therapy. The navigators already met with them and they say they don't really have any support. Or this navigator met with them and they say they don't want to do anything about it. Or this navigator says that, they're going to need X, Y, Z. With this situation, with their stage, the latest recommendation is X, Y, Z. Even for things other than multiple myeloma, we talk about whether it should be surgery first or chemo first. It's this multidisciplinary approach that has your medical oncologist, your specialists in there, your surgical oncologist, the radiologist, pathology. They have your slides on the screen. This happened, that happened. There's so much thought put into that 15, 20, 30-minute visit because I hear so many patients saying, well, he just came in and walked back out. That's valid. I don't discount that. I don't discontinue that. But what I do try to also explain to patients that he talked about you way before you got here. He's been thinking about this. We've worked on this. This has happened. That has happened. You have questions? Let's go back and ask. A physician that you can't have questions and that cannot answer your questions is not the right physician for you. Let's start there. So ask the questions. But what I want to say also about us when I talk about self-advocacy is owning our stuff. First, we got to meet ourselves where we are. The easiest and best patient to treat is an informed patient. When I say informed patient, you don't have to know medical jargon. I can't pronounce non-chemo drug. And I hung chemo a lot of years. I was the director of a cancer center for a lot of years. I can't pronounce them. They change every day. Everybody pronounce them different. They don't know. That's why all of them got abbreviations and names and logos and slogans. We don't expect you to be able to pronounce them. But I expect you to be able to tell me something about your family history. I expect you to be forthcoming about your social habits. I expect you to be able to tell me about your comorbidities. I expect you to be able to tell me about your primary care physicians and whom you've seen. And to be honest, if you haven't gotten one, so that we can get you set up with one. Everyone should have a primary care physician. When we get sick, we want to see the best that there is. But what about those things that happen to prevent us from getting sick? The primary care physician is the quarterback to your health. If you have a primary care physician and he makes that referral when you get sick, when you get to that specialist doctor, you don't have to start at ground zero because he has your records. He knows what you're taking. He knows what's going to interact with what he wants to do for you. But if you don't have a primary care physician and you walk in the door and your blood pressure high, all your labs out of whack, your diabetes is high, we got to go through a plethora of tests. We got to rule out all these million other things before we even get started on what you came to talk to me about. Think about that. So we talk about we have worse outcomes as a people, as African American people. Most diseases we detect at later stages, which lessens our treatment options, poor prognosis, higher our mortality rates. That's because we come in half-cocked. Everything can't be blamed on the system, the man, and everybody else. Y'all know I'm saying something else. We come in wrong. We got to self-advocate. We've got to own our stuff. That don't mean that when we get there, we're not supposed to be treated fairly. That don't mean when we get there, the health system has a ton of disparities. Life does. But we can't add to them. We can't come and everybody that gets sick at some point go to an angry stage. It's common. It's going to happen. We do it. Everybody want to ask why. Everybody gets angry. But you can't come in your healthcare providers with that angry disposition, with walls that it takes multiple visits to break down. It takes multiple trials and errors before you open up and say something. You've got to meet yourself where you are and say, listen, I drink. I have high blood pressure. I don't take my medicine because it messes up some more stuff that I don't want to talk about. We got to be real. Because we want optimal outcomes, but we're giving half of us. You got to lay it all on the table. You just got to, it is what, all of us have vices. All of us do something. Ain't no big and little sin. All of us do something that we ain't got no business doing. Some of us do more than others. But all of us do something. And ain't nothing you can come into the office and say you do that we have not heard. Or do. Let's start there. No one lives perfect lives. Physicians practice medicine, but they don't do everything that they practice. You got physicians that smoke. You got them that's obese, that's overweight. They live life because they live in the same world we live in. So there's nothing you can come in and say that you do that we haven't heard. So be honest and lay it on the table so I don't give you anything that contradicts or interacts with things that you do. And then let's work on a plan to stop doing them. But you got to first meet yourself where you are. So self-advocacy is big. But not only that, is that we got to educate ourselves to what we need and what we want. We got to know what questions to ask, when to ask them, and how to ask them. And another way you know is to keep asking questions. It's not a dumb question. If you don't know, ask. You have a question, ask. Ask until you get the answer that you're comfortable with or the answer that you want. That person can't answer, ask somebody else. Ask Google. When Google tell you, go back and verify. But ask. The easiest patient to treat is an informed patient because you're on top of your game. When we go to our primary care visits, we see them once a year if we're in good shape. Some people take medication, have to see them every 3 months, every 6 months. But we have our mammograms and they do our self-breast exams. They don't know what your breasts feel like. They're looking for something grossly abnormal. You supposed to be doing self-maintenance and do it every month. So if something pop up this month that wasn't there last month, you know that there's something wrong. That's what we got to be about everything when it comes to our health care. We got to know our bodies, our symptoms, what's going on with us. You know if you failed last week, cutting the food, dancing, doing whatever you do, had a couple, that's why my back hurt. But if not, all of a sudden, I just got this back pain, and I don't have no rhyme or reason, I'm just going to keep taking Tylenol and keep taking Advil and keep taking ibuprofen and messing up my kidneys and doing all kind of other stuff and coming and say, instead of saying why I got this back pain, then you go to the doctor and don't tell them about the back pain. Come on, y'all. We just go, everything, okay, I just need my refill. Refill what? You know, the little blue pill. You know you got it in your records. But in between that, you done went to the emergency room and they gave you another pill that worked for the same thing, and now you're taking both of them. That ain't nobody's fault but ours. We tossing the blame. In a perfect world, all the EMRs should hook up and everybody should know what you're taking. But we don't live in a perfect world. It ain't gonna never be perfect. Healthcare is lots of disparities. With the current climate and political income, it's not gonna get better. It's gonna get worse before it get better. So who has to get better? Who got to be on top of their game? Who has to advocate for you? Write it down. Keep a record. Keep a book. Anything that anybody give you, anything anybody say about you and your health care, what we love, we protect, we honor, and we speak on. Everything but ourselves and our health. We protect our children, our spouses, our jobs, our positions, labels, and titles. But we always put our health and ourselves on back burners. The young lady in her statements just said that you can't pour from an empty cup. If we don't take care of this temple that we've been blessed with and honored to have, how are we providing for everything else around us, and how long can we run on that empty tank? You can't. We got to protect our mental health. That's big. Nobody likes to speak about it. But if you're weak mentally, that don't mean you need a check. That don't mean you need to get medicine. Sometimes it's just self-encouragement. Sometimes it's just looking yourself in the mirror every day, self-affirmations. Sometimes it's just seeking God. But it's awareness, how easy it is with health, politics, children, family, to fall into these depressive modes where nothing else really matters, or where we just float through life, and next thing we know, we look up and it's piled up to here. So mental health is important. That's part of being your self-advocate, that you got to know where you stand. You got to know when you're slipping. You got to know when you got to step out as your caregiver, as a caregiver, as the patient. We've got to know when we got to hit pause and say, I got to do something for me. I got to do whatever it is that puts me in my happy place. I got to do whatever it is that makes me feel good. I have a tough day. I know I got to go sit at somebody's bar, excuse me, Pastor. I need me a brown liquor, and I just need to think for a minute. That's me. That's what I do. That's what works for me. I don't get drunk. I can drive home. I can pass the test. I can do all that. I'm going to be at Bible study Wednesdays. But that's what I need. Like I say, we all got our vices. Okay? So you have to do, some people want to go meditate in a room. If that worked for you, do that. That's my daughter. I hear her in the room. She got her sound bowls. I be saying it's nice not to have nothing to worry about. Be able to hear the sound bowl, but okay. But that's what worked for her. Some people need friends. I'm an only child. I entertain myself all my life. I don't have to have a group of people. I need my seat at the bar. That's what I need. That will work for me. Talk to me after that. I'm good. Tell you anything you want to know. Let's talk. Let's shoot the crap. Let's do whatever we need to do. So you got to find what works for you, what motivates you, what puts you in your happy place, what gives you that, what fills your tank, gives you gas to move forward, to think clearly, to make informed decisions. In order to make informed decisions, you got to know what you're making a decision about. You got to have all the details. You got to have discussed it with somebody that know more about it than you. That's another thing. When you create these support systems, you got to create a team. Everybody want a winning team. Everybody want to be a Dallas Cowboy, right? Yeah, everybody want to be a Dallas Cowboy. Come on, y'all. Y'all want to win. Everybody want to be a Dallas Cowboy. There you go. But everybody don't want to win. We got to put them on the bench. So all you negative people, friends, family, sisters, this, that, and the other, I love you, but I got to put you on the bench in my life right now because I don't need that toxicity in my environment. I'm advocating for me now. I'm fighting this battle for me now. I want to live. I got to put all that toxicity on the bench. Anybody that can't encourage me, I got to put them on the bench. You always need somebody in your circle smarter than you, that know more about this than you. Put them in your starting lineup. We go through seasons in life, and this season, I need this particular team to take me to my next level, to my next step where I need to go and what I want to do. Let's talk a second about clinical trials. As a people, Eye enrollment participation nationwide in clinical trials is about 6%. You know why all these therapies have advanced? You know why CAR-T is on the market? You know why we're able to heal multiple myeloma knowing using what we have inside of us and making it work? Because it went through somebody's clinical trial. And unfortunately, when it went to that trial, there was nobody in it that looked like us. Imagine how we can make this thing work if we had some people that looked like us, that had some marrow like my marrow in it. You know what, we can go, what? I just told y'all the cure to this thing, and y'all ain't even heard me. But we can't be resistant to clinical trial based on history. We hear cars break down every day, but we get in one every day and ride. Planes falling out the sky left and right, but we get in them. But the least little thing goes wrong that we can say because they treated our people like this, or we think this, and most of us don't even really know the real story. But we take it and run with it and just say we ain't doing no clinical trials. Make informed decisions. I ain't telling you just go sign up for any clinical trial because they putting a little trinket out there and say you're going to get this gift card. Don't do that. But if it's one that's going to help you, and if it can't even help you, but you know it's going to help the next generation to improve their outcome, think about participating. Think about it. If you read the information, get the education, you've done more than most people do. Take that step. Then if you have the opportunity to enroll in consent, consent is fluid. The moment you feel uncomfortable, the moment you feel like this don't make me feel good, I don't think this is working for me, I unconsent. Y'all take this trial and go on, do whatever they're doing, but I'm done with this. Consent is fluid. But don't count clinical trials out, because that's how we get to the cure. If we can't test the medicine, and if we're going to test it on animals and people that don't look like us, we always going to be on the bottom end of the prognosis of how it's going to treat us. Because they're basing our treatment off of European participants. When we start to participate, then we can say, well, for the average black woman, it's going to do this, and this is going to be the percentage. For the black male, this is the percentage. But when we're not in the number, we can't expect the outcome. So that's my spiel. Know yourself. Know your history. Know your family history. It's important. Know your genetics. Have open conversations about your health with your family and your children. I can't encourage that enough. Be honest. Know our comorbidities, manage them, get us a primary care physician, live well, eat well, go have your seat at the bar, and be happy. Thank you for listening.
That's wonderful. Which bar is this now? Let's get Dr. Blue, Dr. Popplewell, Dr. Donovan, please come on up here. If y'all would sit in the middle chairs, I'd appreciate it. That was just great, man. That was great. If you have a question, raise your hand. I'll come around to you. There are two people I'm going to start with in just a couple minutes. Okay, I'll get to you in a moment. But before we start having some answers, you got to define for us, because you've used these terms throughout. What does CAR T-cell therapy stand for? What is this CAR thing? I mean, I know what a Ford is. I know what a Tesla, whatever that thing is. And what is stem cell? So, Dr. Blue, Dr. Popplewell, could you tell us these things? Oh, yeah, push that.
Oh, it works better when you turn it on, sorry. So CAR stands for chimeric antigen receptor. And so these are the receptors that are now expressed on the T lymphocytes that came out of your body, but they've been educated, and now those T lymphocytes express that receptor, so now they can have some vision and see those enemy cells.
Yeah, so that's basically,
Could you spell so when you say that, you said chimeric antigen receptor, is that right? So chimeric is what is a chimer, and spell that for them, but it's CAR-T cell therapy.
Right.
So what is
So
chimer?
chimera, so CHIMERA. A chimera was a mythical creature from legend, which was part one animal and part another animal. And so the chimeric antigen receptor is a conglomeration. They put together part of a receptor that is normally expressed on cells, and they've attached to it the specific receptor that latches on to the cancer cell.
yeah, so that's basically right. And the biggest difference, like you heard from the lady in the video, is that there's also a thing called a stem cell transplant. And so if you guys remember my example, what we talked about, how the bone marrow naturally produces new blood cells, okay? Well, what happens is that just like all of us, we had to go through a maturing phase, so we started out as kids, then adolescents, and then we got to be grown folks, right? Well, the same thing kind of happens in our bone marrow, is that as it makes these new cells, it also has to go through a maturing process. When those cells are mature, then boom, what your mama say, you ain't got to go somewhere, but you got to get out of here, right? Because you're maturing, you're grown, so you got to get out of her house, right? And so the bone marrow takes those cells once they're mature, and they put them into the bloodstream. Well, what happens is that we can actually collect those cells before they're mature, while they're still in their like young phase, and we can actually put them to work to get new things. So for example, it's almost like, I don't know how many people in here ever garden or do any things out there in your garden, in the field, but what happens is that sometimes things just not growing right. So what you got to do is you just got to till the soil, you know what I mean? You got to get rid of the weeds, okay? And so we do that with transplant, typically with high doses of chemotherapy. So whatever dose of chemo you think you would have got, this is much higher than that, okay? And so what happens is it just starts over. Like they said, Noah had to come and bring the big flood and then washed everything away, but you got to start over at some point. So you say, well, if you're going to start over, you're going to start over with kids or you're going to start over with grown folks? It's probably better to start off with kids as their infancy, because then they're still young and fresh. You know what I mean? Because we all know once we get in our ways as grown folks, we know how that turns out. So what happens is those stem cells are immature, young cells that can basically grow and make new blood cells after that heavy doses of chemotherapy have gone in and basically hit a reset button and basically kind of cleaned out that bone marrow for whatever might be going on.
So you're bringing in new baby cells to grow.
That's exactly right.
Please stand up. Yes, ma'am. In all your glory.
Okay, thank you. I'm asking this question for a friend of mine who has multiple myeloma. Dr. Blue, are you practicing in Nashville, Tennessee?
I'm actually in Tampa, Florida, at Moffitt Cancer Center. Okay. But what I will tell people to do, what you can do sometimes, is that people get what they call a second opinion, okay? And that's a lot of the things that I do a lot of days is I just literally look over people's chart and I basically say, yeah, your doctor's doing the right thing. Or I look over and I'm like, well, let me just add a little bit of sauce on that. Or let me try to figure out a better way to help you. You know what I mean? And so what I would encourage people to do is to try to get a second opinion. It don't have to necessarily be me in Tampa, but it could be, anybody who would consider themselves an expert in whatever you have going on. So for example, let's just say you got high blood pressure, okay? And your doctor got you on 4 or 5 medicines and it just ain't working out right. Well, there's people who are experts in high blood pressure. So you can say, hey, my general doctor doing this stuff, I'm not getting the result that I want. Let me go get a second opinion for somebody who can be a high blood pressure expert who can actually help me with that. When it comes to cancer, there's people that specialize in literally every type of cancer that there is. So if you have a type of cancer or your family member has a type of cancer, you might want to just say, hey, let me just have somebody look it over and just say, yeah, everything's fine. Or, you know what, let me make some tweaks. And those tweaks sometimes can be the big difference between sometimes people who live and are dying.
Dr. Donovan, though, could you say, so we're here in Atlanta where we have a lot of resources, but you're up in Nashville, which is not it's not a small town, but how do you where do you go to look to see, hey, I want to find an oncologist who was up here, because I'm going to be moving to there, or my friend is up there in Nashville, how do I identify a place? And then how do I identify a place that's reputable? What are the key things we need to look for?
I think that's a great question, and you guys chime in too. But I think a good place to start is where you're currently at, right? I think ask those questions and challenge that. Hey, I hear what you're saying, but where else can I go for a second opinion, right? Can you give me somebody else in another state, or can you get me a list of experts? Let me research this myself. Let me make a few calls, or can you make a few calls and see where else I can get in? I think everybody should be encouraged to have a second opinion, to be fully informed before making a decision.
So again, I'm sitting here, and so I know, okay, we're in Georgia, University of Georgia. Let's see, we know that Georgia's in the SEC, and the SEC includes Vanderbilt. So I know about that. How do I know that Vanderbilt? What about Dr. Popper? What do you say? How do I know? Is Vanderbilt the place I want to go to, or is there an equivalent of a North Side up there? Is there a book that one goes and looks and says, hey, here's some place where I might want to go look?
That's a tough one. So I know some of the experts in my field through my participation in the American Society of Clinical Oncology, the American Society of Hematology.
Yeah, but you're here. This is de novo, fresh meat here, trying to figure out where to go. My loved one is sitting up there. My child is in Nashville, and doctor said, you got this problem. You need to see an oncologist. How do I know what oncologist they need to go to? Where do you start? What's that point?
I think looking and seeing some of the research that's coming out of those institutions.
I'm not looking at research papers.
Everybody
Can I answer that?
needs a quarterback to their health care. You start with your primary care physician. They should be able to refer you to an oncologist. From that oncologist, you ask them for a specialist, or you ask them for a second opinion, or whichever specialist they sent you to. But everybody needs a primary care physician, especially the layperson that don't know specialists, that don't even know what a cancer doctor is. All you know is cancer. That you need to go and look for an oncologist. Start with your primary care physician.
And can I just ask something real quick? Because, I deal with this, like I said, literally every day. Us as a people, I'll tell you, sometimes we some real loyal people. You know what I mean? And we feel like, well, I done been with Dr. Jones since 1975. I'm telling you, Dr. Jones treating you with the medicines from 1975. And I'm telling you, you laughing. I'm telling you, it's not cheating on your doctor. It's not a bad thing. You know what I mean? Like I'm telling you that these things that I see sometimes are really changing people's lives. You know what I mean? So, and again, other people are doing this in other communities much more than us. You know what I mean?
Dr. Blue, you got to quote the philosopher Pryor, who said in the character Mudbone, I'm in love with a woman I cannot stand. But you have, now, but the point is, and you all are dodging this, I know about the Moffitt Cancer Center. I know about the City of Hope Cancer Center. So am I supposed to just open up the phone book and say, okay, I go to the university, or do I go to the equivalent of a North Side that's someplace else? How do I sitting here to my person who's away, tell them, okay, this is where you, and I know what you mean, Ursula. Yeah, the primary care doctor up there is going to be the one, obviously, who should be giving it. But is there something that we can look at?
I would say two things. I would say two things to do. If you really want to see a specialist, right, and you say, hey, I have this problem and I want to see a specialist, the two things you can do by yourself. Number one, if you can type it in Google, anything, you just type in literally lung cancer expert Atlanta. Boom, you're going to get a list. You type in Google, high blood pressure specialist, Atlanta. You're going to get a list, okay? But the other thing you could do is get your insurance card, flip on the back. It's going to be a 1-800 number, okay? You call that number and you tell them and say, hey, I got lung cancer. Because, again, you don't want to get no big check, right, or a big bill, right, and say, hey, I went to this doctor that's not what they call in-network. You know what I mean? So you flip on the back. It's going to be somebody who answers the phone, okay? It's going to be probably some computer thing at first. Press 1 if you have, But once you get through that, okay, and it's going to take some work on your part, because, again, it's a big insurance company. But if you go on the back of that insurance company, you will talk to a person, and you will say, hey, this is who I need to see. Who can I go to? And they'll point you to people who are actually covered under your insurance. All right, so you're not just, because Google not gonna know. Okay, Google will tell you a list, so you might come prepared and say, hey, I saw that there was a Dr. Blue in Tampa. Am I covered to see him? People come see me from all over the world. You know what I mean? And so, especially with, when COVID and stuff happened, people do what they call televisits. So they do these virtual visits. So they sitting in they, living room, but they seeing me who are miles away. You know what I mean? And so that would be something very simple that I think that you guys could do is literally on the back of your insurance card, it's a number that says, got questions, call. You call them. And then again, type it in Google.
Go ahead, Ursula.
And let me say too, just about every disease or specialty care have some type of accrediting organization. So if you go on Google or online and look for American College of Surgeons, they'll tell you surgeons all over the world that has center of excellence and that are accredited and specialists in what it said fields and what hospitals hold these accreditations. Look for your multiple myeloma, look for any of your cancers or any of your diseases, hypertension, whatever. Almost every specific specialty or disease have an accrediting quality body that have organizations, hospitals, physicians that are accredited in these areas.
Thank you very much. Yes.
I'm going to piggyback real quick off of that. Also, to that point, you can look up survival data too, so you can see outcomes. That data is public, so you can, again, do your research. And there's nothing wrong with a second or a third opinion. So just because you go somewhere else, and then go a third place until you feel comfortable with the decision that you've made.
And if any of y'all have any questions, you just call one of these panel members. You say, hey, I heard you at this. I'm serious, though. I heard you at Shaw, and, tell me, am I doing the right thing? All right, go ahead.
Okay. Thank you. Can you hear me?
We can hear you.
Okay. Thank you, Dr. Blue. I think the whole panel for what you have given to us. I appreciate that. There's a lot that you've told us, and my head is hurt because you've given us so much information. I'm going to have to look and read, and like you said, check things out for myself. I'm kind of under the impression, the way you talk, it's like everybody in here need to go. And I know you didn't say that, but I appreciate the information that you've given. Thank you so much.
Thank you very much. Thank you. I'm coming to you. Stand up, please.
We all have questions. We want to hurry up and do this thing. My question is, I'm from Howard University, and we did a lot of
would you say
radium.
that again, please? You're from where?
Karen Davis.
Where'd you say you're from?
Don't worry about it.
Come on, Howard.
Washington, D.C. But anyway, we did radium implants in an oncology department. I'm familiar with the different kinds of cancer, but when it comes to this multiple myeloma, I'm wondering, most cancers either is benign or malignant. How do you all diagnose whether it's benign or malignant, or do you with multiple myeloma?
And let me add to that, because there is a pre-stage, so there's MGUS. Would you tell us how that factors into things and when that diagnosis is made, and how do you do with that other than when it's multiple myeloma?
So what happens is like all problems, they start off with a little bit, and then a little bit more, and then a little bit more, right? So you might have had your first cigarette when you was 10, and then it became half a pack by the time you was 16, and then by the time you turned 20, you was doing a pack a day. Does that make sense? You had your first drink when you was, in high school, and then you got to college, and then you really went wild. So any kind of process that turned into a lot, it had to start somewhere. And the same thing happens with cancer. When we're specifically talking about multiple myeloma, what happens is that before it becomes cancer, it's what they call a precancer, all right? And so before you get to the house, it's the driveway, especially y'all here in Atlanta, y'all got some long driveways, but that's what happens. And the name of that precancer is called monoclonal gammopathy of undetermined significance, a mouthful, but you might see just the letters MGUS. And what that means is you in the driveway, all right? Now, sometimes you can be in the driveway so long that you never get to the house, meaning that you stay in this precancer stage so long that it might not ever turn to cancer, but at least somebody is watching, okay? To say, hey, I got this chance that I might turn into cancer. I need you to just to be there. So as soon as I knock on the door, you already ready to open the door and let's start this cancer treatment, okay? Because what happens is that sometimes we have cancer cells in our body and we don't even know about it. So that means we passed the driveway, we running into the garage, you know what I mean? Like we hitting this cancer thing going 100 miles an hour because nobody was checking it, we didn't even know. So when it happened, the whole thing is already at an advanced stage. But if you see it when it becomes a pre-cancer and you can kind of watch that car just keep driving through the driveway, you like, it's getting close, it's getting close. And so at the moment you kind of cross that line, we say, all right, let's get to it. You know what I mean? Before your kidneys shut down and you have to be on something called dialysis, before you break those bones like we heard the lady talk about on her Jamaica trip, before you have all those problems that can happen from this cancer, we can detect it at a point where we can actually start treatment at a time where you can actually have what we call quality of life and not just, a lot of problems.
Dr. Popwell, would you add to that? Especially one of the things which we talked about yesterday was if you go in for you have kidney disease and you get your routine labs and stuff, when do you start asking for some of these other diagnostic studies to be done that may pick up early stage of a multiple myeloma, since we know that there is this leeway, this lead time, and a lot of us don't know we got anything going on, as Dr. Blue just said.
Right, so the MGUS, the monoclonal gammopathy, is where you have a few plasma cells in your bone marrow that are making this abnormal protein, this antibody that's not really an antibody because it's not really protecting you against anything, but you can pick those up early. So kidney problems, anemia that's unexplained, sometimes you can find some of these monoclonal gammopathies. And I have a lot of patients also who come in who have some kind of an arthritis, like a rheumatologic workup. Very frequently, the primary care doctor will send off some tests looking for a protein like that. Sometimes we find it, and it's not something that we have to treat, but we do need to watch it. And sometimes it turns out to be a multiple myeloma that no one really suspected they had.
One thing I would just say, which I think could help with that as well, is I think as someone mentioned earlier, is that you got to know your body, right? So one of the things that happens when people develop kidney issues, because think about it right now, you don't really know what's going on in your blood. You like, I don't know, I bleed, I scrape myself and blood come out, but you don't really know what's in the blood. So for example, like your kidneys, as long as you go into the bathroom every day, you like, I drink and I go to the bathroom, you don't really know are there cancer cells literally that I'm flushing down the toilet. So sometimes what happens is our bodies are made with little alarm signals, you know what I mean, to let us know something ain't right. So what happens is that what I would encourage people to do is that pay attention to some of those things. For example, you go to the bathroom, you need to be looking at the stuff that come out of your body, okay? So for example, when you go to urinate, you see a lot of bubbles, that tells us as the doctors that there's what they call protein in the urine, okay? So again, not everybody was at the bar, but I'm gonna use this sister example of the bar. When you go to the bar, there's typically like a little foam that's at the top of the beer, okay? It looks like bubbles, okay? But that foam, if you see that in your urine, you need to be telling somebody, right? And saying, hey, this is a problem. Again, this is something that we can detect early. Also too, when you're having bowel movements, you need to be looking back there. What does that look like, okay? All right? Is there blood when I wipe, okay? You need to know how frequently you're going. So for example, some people say, when you last bowel movement? I don't know. You need to know. These are things that you can do to pay attention to what's happening, what's normal for you. And I'll tell you this, nobody knows you better than you, okay? And so you need to be, as Sister mentioned, your own advocate to say, listen, I know at 3 o'clock every day, that's when I gotta go, you know what I mean? And when 3 days go by and it's not, you like, something's off, you know what I mean? Well, you can detect it early. So I would say those are some of the things, just know what happens, actually look at the stuff that's going on, and I would say another thing too, talk to people when you have a problem. So sometimes, I think someone mentioned earlier, the lady in the video, she was saying that she actually had cancer and her own sisters didn't know it. You know what I mean? So unfortunately, with some of those types of problems, she could have been hurting her sisters because they could have got detected, right? They could have been screened. You know what I mean? And instead of her having an advanced stage cancer, all right, well, let me let my sister know so that my sister can maybe get it at stage 1. You know what I mean? But my sister didn't know because she going to the doctor and saying, anything running your family? No, I don't know, you know.
but it's because she kept her mouth closed, sometimes those problems happen. So I would say those are things, know your body, and then if something does come up, you gotta share it with the people that's close to you, because again, what you don't tell them could be hurting them.
Okay, we have a question.
So I was actually diagnosed with multiple myeloma back in September. And the reason I was diagnosed is because I couldn't get off the couch. I had so much pain in my back. It turned out that there were multiple breaks and cracks in my bone. I went through kyphoplasty a couple times. And I'm saying this to say how much of it might have been in my body. My doctor didn't give me a stage, but he said that it was in my head. Well, as of March, it was undetectable.
Ain't God good?
He never used the word remission. He just said undetectable. So instead of going twice a week now getting multiple shots, I go once a month, and the Revlimid was decreased dramatically. But I was interested in what you were saying about the CAR T cells. I would much rather my own body take care of it than having to do this once a month. The fact that it's undetectable now, is that CAR T cell something I should wait until, or if it comes back, or is that something I could pursue right now?
So Dr. Popperwell, I want you to address this, but also, because you talked about this as far as clinical trials, what is the timing of who and what gets the CAR T cell treatment versus, as he talked about, as far as he started with this therapy, do you have to wait for something to fail and then get it, or can you start off with that? So if you would address that question.
Sure. So CAR T cells are not approved for patients in the front line, but they are approved for the first time a patient needs a second treatment. And so you have done really, really well. Congratulations on all of that. You may be in remission or undetectable for many, many years. And so I would ride that out as long as you possibly can. There might be newer, different CAR T cell products available by the time you need something new, and hopefully you won't.
You know, always tell people that it's kind of like, remember when COVID came out, right? It was a lot of people getting sick, the hospitals was bursting at the seams, and then we found a vaccine, right? It was like, all right, we got something that potentially might help save some people. But when the vaccine first came out, it wasn't given to everybody. He was like, well, who need this the most? You're like, all right, the people who really about to die from this thing. So people who are a little bit older, people who had what they call a low immune system. Then after those people, they kind of spread it out a little bit. Then now these people can get it. And then now these people can get it. And then eventually it was for everybody, right? The same thing happens when we get these new medicines. Yes, CAR T is a new medicine. They used to say, hey, you used to have to be on so many different medicines and then you can get a CAR T. And then they said, all right, now that those people who didn't have any other options, we had to give it to them first. Now it's coming a little bit earlier in lines. Eventually, it likely will be for people who are newly diagnosed. Does that make sense? We're just not there yet because it's a new treatment. But that's what happens is that any new medicine that we have, it typically never happens for the people who are at the beginning because we got so many options for the people who are at the beginning of their journey. And so for the people who may unfortunately not have responded to the medicines, you know what I mean? Now this is a new option that's available for them. But I will say that that's just why research is important, because there are clinical trials where they flip a coin. Some people newly diagnosed do get CAR T up front. You know what I mean? That is something that is a research protocol. And so I would say that there's always options available, you know what I mean? And so that's why I'm saying it's just so important for you to see somebody who do this every day, because they can just kind of tell you and say, look, man, this is what's available to you, and can kind of talk to you about, you know, some of the options.
I think the most remarkable thing is to see how well he's doing for his, because he was carrying all kinds of heavy stuff when he came in here this morning. So no. All right, now, we're kind of lucky in that we have a state representative, Representative David Wilkerson, here with us today. So let me ask you, so when we talk about, you know, physicians, we think we are the healthcare world. I think probably more healthcare decisions come out of the legislator than what it is that we do. So what's going to be your response when we look at some of the changes that are going as far as affecting how health, you know, especially Medicaid, and how health insurance is going to be covered for us?
Thank you, and thank you, Pastor Morrison, for having this here, and I always appreciate when I can come. But That's a great question. I think right now, with all the cuts you're seeing in D.C., it's a terrible time. I'm getting calls about food. I'm getting called about our young people. I'm getting called about seniors not being able to get food and medicine. The one thing that I'm going to kind of veer off for a second is Monday, the first call I'm going to make is to the Speaker's office, because we right now, I don't know if you know this, we're having a study committee on cancer care. I don't know if anybody's aware of that. Anybody aware of that? And we talk about information's key. The way these study committees work is that there is one person, either the Speaker or the Lieutenant Governor in the Senate, gets to pick who's on this committee. Now, if he picks only the people that he knows in the communities that he knows, then a lot of communities are going to be left out. And so I've been talking about this for the last year, is that we need to have different people sitting at the table to have these conversations. Because you brought up a great point up there earlier about how important it is to talk to family, because you could be risking your family member's life by not communicating the challenges you have. Because I know when I go to the doctor, I used to always say, I don't know what my family has. You go down the checklist because we never talked about it in Black families. And so your point is, yes, we should be concerned. We have to talk to our legislators, because it is going to be a very rocky road right now. The federal government has pushed everything to the states, and the states are too afraid to say anything to challenge at the federal level. And so we're going to have to push back through these communities. And so, yes, the first thing I'm going to do Monday is try to get Ms. Mosby, we're going to have to talk about how we get of different opinions into this meeting, even if they're not on the study committee, that they share those opinions, because we need the experts to tell us. Because what ends up happening is, where that study committee goes is we create legislation. The legislation then creates money that follows it, which it gets back. So if we're missing a big gap in that, then I think that's going to cause issues. But thank you for letting me say a few words. And like I said, I'm not going to take 20 minutes, but thank you.
I want y'all to write that down. That was the fastest time I ever got a microphone back from a politician. That's good. That's good. So please, ma'am, stand up. Then we'll get I want to get a comment from you all about that in a moment. But first, I want to get this question.
Okay, so I don't have multiple myeloma. I do have anemia. So my iron levels were very low on my last visit to my doctor. I didn't realize what that could do. I spoke to a doctor yesterday, and he told me that, one of your panel members told me that when you do your lab test, just ask the doctor to do a myeloma draw on you, so you can see if you have myeloma. If someone were like me, just a basic person that has anemia, what would be the next step if you're told, yes, your myeloma, you did have a myeloma lab test, and we do show that you do have it? What would be the next step for us?
And that's an important question. What do you do when you get that diagnosis? So I want to start with Dr. Donovan first, and then Ursula. I want you guys to address this. What are those steps that take place? You got, your new diagnosis, now what happens to me? And by the way, we hope it turns out to be nothing too bad for you.
Yes, and I appreciate you stepping up, and I think that's a common question. So you did the first thing, right? You've got those labs. I think you follow the recommendation that primary care doctor should refer you to a hematologist or an expert. You go, right? And that's it. You go one step at a time. You go to the next appointment and the next appointment, and you get a little bit of information at a time, and you start to feel comfortable to tell a little bit, a few more people at a time, and you get that support.
Ursula, I'm going to let you go. I just want to make sure that people understand this, because this is an important opportunity that I need to say. Everyone in here can get checked for myeloma for free, and I'm going to tell you how to do that. From your phone, right now, everybody has Google or some type of search engine. You type in 2 words, PROMISE study, okay? The PROMISE study is allowing us to look at people who have multiple myeloma. The inclusion criteria to get on the PROMISE study is to be African American and to be at least 30 years old, okay? That's it. 30 and African American. What happens is you sign up, we send a little kit to your house, and you take that kit to Quest. Now, it's Quest all over Georgia, all right? So you ain't got no excuse, all right? And it's free, all right? And you can find out if you have this disease that we've been talking about all morning, all right? So there's no excuse for people to know. And you can have your whole family. Y'all do it at the family reunion. As long as they 30 and African American, they can do it, okay? Because what we're trying to figure out is just how the same way you reach a certain age, you get a colonoscopy. You reach a certain age, you get a mammogram. What we're trying to figure out, does it make sense to reach a certain age and get checked for myeloma? Because right now we don't have a screening for it. And so this is helping us not only get involved in research, which is what we talked about, but also helping you to figure out if this is something that you have. So again, you go to Google, just type in literally 2 words, PROMISE study. And this is a free way for you to get checked for multiple myeloma. So I just want to make sure that that's very clear. And like I said, we send it to your house. So no excuse. But don't leave it on your front door. Don't leave it on your dining room table once you get this kit. Just take it to Quest, you get checked, and then they'll let you know. So
Go ahead, Ursula, please.
So first of all, thank you for asking the question. And the first step is, like she said, you just show up, go and get tested, do the PROMISE study, however, whatever method you do, just go and get tested. Then we're going to trust God with whatever the results are going to be, because the provisions have been made. We just got to walk into them and do our part. So we're not going to fear. We're not going to let fear dictate our movements. We're going to trust God that whatever this is, He's made provisions for me, that we're going to see it through. And we just got to trust and believe that.
And I think we also have to add, as we heard yesterday, don't procrastinate. Once you got the thing, start on the journey. It's an agreement between you and the healthcare providers. You're going to do your part, they're going to do their part. We got to hold each other accountable. Yes, ma'am, you had a question.
Thank you. Okay, my question was, Dr. Bloom, you had talked about immune system fighting, but what if you have a low immune system? Is it still able to fight it? And my second question was about the clinical trial. I had cancer, and my doctor at first said, oh, you might be able to do this clinical trial, but as I went through, he said, the clinical trial won't work for you. So how do you know if you're fit for a clinical trial?
And let me put it, Dr. Blue, you take that first one, because you did a great thing of showing us how the immune system works. So tell us about that. Yeah. But then, Dr. Popper, if you will pick up, I don't know why I said that, Dr. Popper, I don't know why I said white, I apologize. If you will then comment, who pays for this clinical trial if I'm on this thing?
Yeah.
Am I picking up the tab? So go ahead.
So if you guys remember from my example, the reason why I told the brother right here, this is the biggest guy in the room, right? And so typically your immune system is one of the strongest fighters, right? So what happens if you don't have a strong immune system, right? Like, can CAR T and some of these things still work for you? Well, I'll tell you that what we know is the stronger the immune system, typically the better people will do. I'll be 100% honest with you on that. Like that is something that we typically see. However, we have ways to sometimes boost people's immune system, okay? So what happens is that sometimes your immune system might not be as strong as the brother right here. Well, if this is a therapy that you need and a therapy that we think will help get rid of your cancer, we can sometimes boost the immune system to still be able to help. So I wouldn't say that don't let that deter you, you know what I mean? Or there might be some medicines and things that we can do to kind of help get you there, okay? So not having a strong immune system is not what we call exclusion criteria.
All right, Dr. Popwell, who's paying for this clinical trial if I get put on it?
Who pays for clinical trials?
So if I'm getting a drug in the clinical trial, is my insurance company supposed to pay for it? Am I supposed to pay for it out of pocket, or are you paying for it?
So the answer is that depends. All right. So clinical
Are you in
trials, clinical trials that are further along, that are looking at comparing treatments that are already available.
Yes, ma'am.
Often the person who's paying for a clinical trial is your insurance company, right? So if Revlimid is part of the clinical trial, then probably it's standard of care. It's going to be billed to insurance just like any other prescription would be. If it's a new treatment, then either the pharma company that's sponsoring it, or if the NIH is sponsoring it, whoever's sponsoring the clinical trial will be paying for that.
So the other part of the question which she was asking, she's not going to get hit with this astronomical bill to cover the medication if she's participating in a clinical trial beyond what ordinarily she'd have to pay.
Right. The answer is that you're correct. So our goal is for the patient never to be surprised with any kind of a bill. And so those are important questions to ask when you get ready to participate in a trial. And that's why we have to go through and make sure that you meet all the eligibility criteria. And then generally we'll tell your insurance company this patient wants to participate in this clinical trial, and here are the particulars. And, I came from California where clinical trial participation is guaranteed as a right. It may be different from state to state, but we will tell you the answer to that before you get started.
And I think that's a very important comment, please. So for those of you who have not registered to vote, and I'm sure there's nobody here, and for those of you who haven't bothered to show up and vote, and I hope to God that there's no people like that here, because Representative Wilkerson made the good point. He's going to take it up when he gets back to the legislature. If we're not paying attention, these health care benefits that we're talking about, they're going to disappear. And believe me, there's certain folks in D.C. who probably, Mark, I think it's Mark 2, but I can't say exactly, but I don't know what's in a man's heart, but I can tell you about what his voice says. Mm-hmm. So we need to support people like Representative Wilkerson by any other name so that we can have these kinds of things. So please tell everybody to go out there and vote. Yes, sir.
Dr. Wilson, if I can answer her question,
yes.
she said that she was a cancer patient and they told her she was no longer eligible to
Not
participate.
eligible, yes, please.
So clinical trials come with some exclusions because you got to think, because it's a trial, sometimes they say that they want only females. Sometimes they say that if you've had chemo in the past, then you can't. Each trial comes with some exclusions and some inclusions. So maybe for that particular trial that he was looking at, because of some of your medical history or something, you didn't meet the criteria to participate in that particular trial.
But I know Dr. Blue knows this as well as anybody. As you recall, there are only two diagnoses you never make, the one you don't know about and the one you don't think about. And sometimes people won't recommend a clinical trial because you guys talk about it. They don't know about it. So that's when you pick up the phone and you call somebody like these folks up here. Yes, ma'am. Please stand. What you got?
So thank you all for your presentation today. I have a two-part question. They're related to clinical trials. So we know that African Americans are traditionally underrepresented in clinical trials due to a legacy of mistrust, systemic health inequality. What are some tangible things that providers, patients, advocates can do to increase the numbers and move forward more towards health equity in clinical trials?
So,
go ahead. Whichever one you want to jump in on that, because that's a great, great question.
Yeah, I think information access is probably one of the most important things, and discussion, right? So clinicaltrials.gov is a great resource if you're interested in a clinical trial. You put in your diagnosis, you put in your location, it'll tell you all the areas around you that are offering clinical trials, and you can dial in. You can say, of a certain age or a certain sex or a certain phase of your disease.
Now, I want each one of you to give us the take, because we got to wrap this up, unfortunately. Now, these people are going to be around, so we're going to block the exit so they can't get out. So if you could, we didn't tell you that part. So I want you to be sure and come up and ask them. If you got questions, ask them. Now's the time. But let's do this. I want you to each give me a 1 minute. I can't say bad. My wife says trees fall over dead, so I'll stop talking to them. So I can't say anything bad. But I want a 1 minute summation of what you think is the most important thing we should take home from all this. Dr. Donovan, Dr. Popperwell, Ursula, then back to you. Each one of them.
All right, I'm starting. So, all right, let's see. I think showing up, I think we've heard a lot of good things. Show up, advocate for yourself. Show up when you're scared. These people around you, you're all here together. You're all, if you start talking, you're all fighting the same battle, right? The resources are there. Ask the questions, challenge your providers to give you the information, the financial resources, the clinical trials. If you're unhappy with your provider, ask for a second opinion, right? I just think challenge, right? Challenge the system. Be vulnerable and be comfortable with your team to show up and get the care that you need.
Thank you. I agree with all that. So asking questions is important. I always tell patients it's not just the patient who has the disease, it's the whole family that has to help deal with it. I worry so much when I have a patient who shows up over and over again to a clinic appointment, by herself. Because when you're in a high stress situation like that, you're not thinking, you're not asking questions, and you're gonna go home, and by the time you've reached your house, you will have forgotten, a percentage of what you heard. Take notes, ask questions, and bring an extra set of ears to your clinic appointment, somebody who will think of questions that you might not have thought of.
I ditto both of those comments, and I think for me it's self-advocacy. Meet yourself where you are, be true to thyself, and do what it takes to succeed and make the necessary changes that we have to make to get where we want to be, to live and to thrive while we live. We don't want to just exist. We want to live, and we want to live well. We're royalty, we're children of the King. There's nothing out here that we're not deserving of, but we've got to prepare ourselves to receive it and to walk into our blessings.
I think for me, first off, I want to just say to answer your question as well, when you talk about, Black folks being involved in clinical trials, there's actually a lot of data that shows that if you just ask Black folks to be on clinical trials, that we say yes at the same rate as other folks. You know what I mean? So I think the job for us as the healthcare system, we need to just ask. Because a lot of times what happens is that people come in and we make certain assumptions and we don't even say nothing. We know that we got this clinical trial right in our back pocket, and we say, she had to get on the MARTA to get here. She ain't coming. You know what I mean? She live all the way in Smyrna. You know what I mean? She not coming. And we don't even ask. So I would just say that's a big thing that us as the healthcare system probably does have to work on. But just throwing that out there, just so you know that for us as Black folks, it is something that as long as we get asked, we do say yes. But as far as a summary of
See how you took that 1 minute?
I know it. Three things. First thing I would say is, I appreciate you guys all for being here, right? Like, being here is like the first step. Wanting to know more about your body, wanting to know more about your healthcare. And so I would say as a first step, I would just say, just know what's normal for you. I think that's very important for people to do. Know what medicines you're on, know what comes in and out of your body. Number two, I think that if you do have somebody who could be with you when you go to the doctor, I think that's always important, all right? If the person can't be there in person, because a lot of diagnoses that happen for Black folks, we get diagnosed at younger ages, so that person might still be working, might not be retired yet. So what you need to do is call them on the phone, do a FaceTime, call somebody, and just make sure that if they can't be there in person, just say, hey, you ain't got to be here for the whole thing. 10 minutes, take your lunch break right now, take a quick break, to hear this else, because it is important that somebody else is with you. And then number three, like I said, because we're talking about multiple myeloma, the PROMISE study is something that's very easy, it's free, it's something that you can do, and we will send it literally across the country. You know what I mean? So you don't even have to live in Georgia, Florida, whatever. We will send it straight to your house, and it's something that I encourage everybody to do, PROMISE study. Again, the first website that comes up in Google, it'll help you, and like I said, it's just a way that we can all get screened to find out if we do or don't have this disorder.
How about a hand for this outstanding panel, please? Outstanding. Y'all did a great job, man. We have two things to do at the end. There will be lunch at the conclusion of this program. That's the good news. The bad news is the two things that are standing in the way of lunch, and it's not me. One of them is a former politician, and the other one is a pastor. You know what happens when those two kinds of people get a hold of a microphone. However, that said, I'm going to turn it over to Mr. Howard Mosby from HEAL Collaborative to get things going, and then he will give it to the pastor, and you can blame them, not me. Thank you, sir.
Let's give Dr. Tuxson a hand. Those of you who were here yesterday know that I said that Dr. Tuxson was crazy. We are going to bring in a mental expert that is going to actually verify that that is the case. No, he's a great member of our team. We appreciate everything that you've done. You drove this well, sir, and I just want to say thank you formally. You all are now part of the HEAL family. I am just excited by the fact that we were able to bring this program to you. Pastor Morrison opening up his house to let this happen. You all coming. This is not a program without you sitting in these seats, without you taking this information and being able to take it out into the community. And so it might not directly affect you, but it does directly affect you because all of us are connected. We live in a community. I can't live by myself. If I went to Publix today and nobody else did the work, it would be nothing in the grocery store. So we all are relying on each other to make sure that we live this life. So I'm glad that you're all here. And I want to say, give yourselves a hand for being here. 2 days, 2 days, that's an awesome commitment. But this is a commitment about your life, your future, your grandchildren's future. Because everything that you learned today is being pushed forward in time. And so we want to say thank you for that. On behalf of Heal Collaborative, thank you for allowing us into your lives for these 2 days. Where's my Heal family? Y'all stand up. They've done a great job in pulling this off. They stayed up all night cooking for Chick-fil-A to make these sandwiches. So if it doesn't taste like Chick-fil-A, you know where it came from. Okay. And then finally, I want to say thank you, Pastor Morrison, please. Come on up, sir. We want to say thank you so much, man, and we are just so happy that we're here to do this. We know we're going to do more of these together, and this guy, we called him up. He didn't know me from Adam. He didn't know me from Adam. He said, my door's open. My people need to know. Come on. And so I want to say thank you, sir. And I'm handing it to you. And now this is the reason why you don't get lunch.
Thank you, Howard, and to the Heal Collaborative family, the Kite, and to everyone who helped to make this these 2 days possible. And thank you so much for the conversations, the inspiration, information, to let us know how to go forward. I told somebody I'm going to try my Sunday sermon now, prolong. But we're grateful for everyone. The collaboration, it's just been wonderful. And we do want to do more of these. So thank you so much for bringing it to Shaw Temple. Let's pray as we share a meal together. We're grateful for everything. Thank you for the information. Thank you for the persons who are here. We pray now that as we close out these 2 days and this conference and sharing, we ask you now to bless the meal that we are about to receive. We pray, Lord, that what's been shared here today might not only be used for us, but for the betterment of our community. In Jesus' name, amen.
I'm sorry. I was reminded. The surveys, please. If you fill out the second part, the post survey, fill it out, raise your hand, we'll come and get it. If you got more questions, talk to people. I know there are a lot of things I still want to know, and I'll ask some of our speakers. But fill out that, and thank you all very much for being here.